Bismillah ar-Rahman ar-Rahim. Your Excellency, Mr. Mansour bin Ibrahim Al Mahmoud, Minister of Public Health, and guests, welcome, Hayyakum Allah. My name is Isam Al-Kharousi, Head of Addiction Counselor. Welcome to Naufar. I'll be your MC today for the second Symposium of Precision Medicine and Substance Use Disorder. Let us now begin our journey with the first session of a general welcome with the Professor Muhammad Al-Ma'adid, who is going to guide us in the vision and road to precision medicine in substance use disorder. Professor Muhammad Al-Ma'adid boasts an impressive career, spanning over 3 decades in healthcare, sport medicine, and anti-doping and humanitarian work. Professor Muhammad is the director of the Center for Metabolism and Inflammation at UCL, chairman of the Board of Trustees, ADLQ, Director General of Naufar. He also led the Qatar Red Crescent Society from 2011 to 2022, transforming it into a global entity impacting millions. Recognized as a thought leader, Professor Al-Ma'adid collaborates with a major sports organization, governments, and NGOs, and has published extensively in his field. Please welcome Professor Ma'adid.
Assalamu alaikum. أهم شيء I have to know how to control my technologies, which is one of my weaknesses. Assalamu alaikum. Sabah al-khair. Assalamu alaikum. Your Excellency, Minister of Public Health, our honorable guests, colleagues, friends, I would love to, on behalf of myself and the rest of Naufar family, to welcome all of you here today on our symposium. This is our second, and it is about precision medicine. And what I'm going to say now is just to tell you why did we choose precision medicine at this moment of time, which is appropriate for our strategy. And I have to say, the response was great. I mean, really, it's fantastic. Look at the numbers. The auditorium is full, and it's 250. Plus that, we have a lot of staff that we had to set up other places within the building that it can cater for them, which is common rooms, meeting rooms. And so we have 250 in this room, but we have over 8,000 that's online. And that shows the significance of this subject. We hope we give it its due right. You know, I've been in this field, or let's say in healthcare, for nearly 40 years. In different positions, in different levels. I've been in, as I said, different disciplines. And each one of them have different challenges. But in addiction, I've been, 15 years? We set up Naufar, and I've been running it. It has its own unique problems. For me, it was the most challenging emotionally, by the way, because you see the patients, you see their families, you see this, and it really challenges from an emotional point of view. Possibly it's just me. And I was talking to His Excellency that we are really lucky in this country that we got all the support. I think those who came and know this place know that we are well supported, especially if they are exposed to other countries' kind of support they get. Usually it have a low priority in funding services and research. Really, they are. But here we have really good support. And you don't blame them, the ministries or whatever, when they don't put them at the priorities, because I was in the position of policymaking as well, and I do understand their perspective. But one of the other things that I think is challenging is the dual burden on the individuals themselves. Like any other patient, we all suffer from a condition or something. We do suffer personally, but we get sympathy. or empathy, I don't know what the right word for it. We got social support, family support, everybody's support. But with addiction, you're actually in a position that really put you in you don't want anybody to know or something like this. You know the stigma behind that. So really you try to avoid, and that's really give you that isolation, give you that feeling of guilt, and people will say, why don't you man up or whatever. And that's lead to a delay on that by the time you come and try to get help for that. By so much at that time, maybe there is so much damage have been done. I think in Qatar, when we calculated, it's about 9 years gap between the time they start until the time they seek help. Hopefully we can change that by changing, the culture into that dimensions. And this is why Naufar is a voluntary a place that they can feel safe here, they can come in. And one of the things that they say, if all the conditions that people do have, addiction will take number one from a society point of view. The destruction that causes to, or the disturbance causing to families and to communities, and also to the national economies as well. So there is a social dimension that possibly specific diseases does not cause that. It does a huge, and a lot of it is hidden. You can't even see it because people won't talk about it. And then there is a long-term generational kind of consequences on a whole generation, or even, with the epigenetics kind of things, but just the kind of environment that they share that it will continue as well in community. But one of the biggest things that maybe it's the key here is this is a subjective. It is qualitative field. Okay. So how is that? I mean, first of all, it's all based on, I can tell you this from the first thing, it's subjectivity, it's encompass everything. First of all, that when we measure prevalence in any kind of disease, there is a ways to measure them. This one, because of we use the WHO, for example, population surveys and this, but still, there is a lot of biases, desirability bias for, people will not respond to your surveys, people will hide things. So there is a lot of things against you to do. Even if the survey is validated and it's well structured, you still do that. In Qatar, for example, we had to do, let's say, a secondary kind of estimation of what's the prevalence here, and we came about 2.1%, and we really think it is quite low. We know it is low, okay, from the things that we are experiencing, something like this. And the problem with such things, if you really don't have a quantitative measures that you are able to really know what your problem is, you have a problem then of putting budget, planning, So you are always short. And the problem is much bigger. It's much bigger. But how are you going to challenge it or this if you don't know it? And that's one of our biggest problems, for example. It's also, then we go to the qualitative kind of subjectivity in our diagnostic challenges. Usually we get our diagnosis from, the patient will tell us what they think. They will report. And then our clinical team will make the subjective kind of their clinical judgment. You see, we don't have, like diabetes or other diseases, definitive biomarkers, definitive fracture. There is a fracture, you do an X-ray and you see it and it's a fracture. And that's difficult here because we don't have it. in this country, or possibly in the Gulf, because the availability of the substances differ. Okay, you don't have the same substance available all the time, so what do you do if you don't find this substance? You take another substance, so you have a multi-substance kind of approach. So if it's difficult to measure one, then you've got a multi ones that, how are you gonna, this is the complexity that we have because of this kind of subjectivities, and you know, it also make you sometimes overlook the mental comorbidity condition like anxiety, depression. You know, I always said, and I'm sure that a lot of those here that they understand this, that you might have two patients coming to you. Okay, same age, same background, same motivation, same substance they are taking. And we do use the best of practices, evidence-based, everything by the book. Okay, and with experience, therapeutics. And what do you get? One recovers, go back, build their families, whatever. The other one will come back to you, said, nothing happened. They relapse. And say, what's the problem? I've done everything you guys asked me of. I put all the energy there. We know there is an individual variability, biological. But what do we tell him? Do we tell him it's because of you, how you are made? We make the condition is worse, because then they feel the guilt as well, above the guilt they have from, because this is in society seen as a weakness or a problem. So even our treatment limitation, we, as I said, we used all this kind of evidence-based, but our relapse rates, I'm not talking, this is general, globally it's between 40 and 60%, okay? But still, there is a large number which really benefited. So I'm not saying that the system we are using now are useless. No, it's actually we are doing quite well based on the system that we have now, which is a qualitative system. But we can do better. See, the system we have now, it is a trial and error model. Trial and error, we'll try it this way. If it doesn't work, we try it the other way. And so it becomes a long process and a tedious process. And this is where we think we can do better. We ask ourselves why. There is opportunities coming up, or came up, which is the new technologies. And these new technologies, the omics, you have your genomics, epigenomics, all the omics that you can go with. Now we have the opportunity of the artificial intelligence and the machine learning. Then you've got all these sensors, the social media kind of monitoring that you can do. So there is a lot of things going for us. And we know that it works somewhere else. In oncology, it works in other diseases. So we are sure that if we really adapt these technologies and go with it, that we're going to improve our results of that people recovering. And by definition, this is what precision medicine say, is to provide the right treatment at the right time to the right person. So we can tell that guy, that second patient that didn't recover, by this time, we understand their personal variability, and we can say, we understand that and we can find. Now we don't know much about that variability. We know something, but we are not there yet. So we decided here that we will adapt that strategy. Some think it's late, it's early, because all the omics, all the technologies, there is a lot of research going on. Some of it at the stage that it is implemented in some centers, but some of it is really very early stage. We say, that's fine. We're going to do it. We're going to adapt that strategy, but to do that, we need to have capacity. We have to be technologically ready. Our human resources have to be ready. Our facility, our system, our budgets, all these kind of things, our culture. And that's when you take and adapt a strategy early. And that's why we decided at this time that we need to do a review, which is this conference. Okay? So what did we do? We built that infrastructure. We built a research unit. We fully staffed it. We registered it with the ministry. And we put a translational strategy, to enable our strategy. Because the whole idea of research is not to publish, by the way. Although people see it that way. It's really how do we improve it for our mission. The most important is our mission. Everything in this organization should serve that mission. And that's what our research is doing, to support our strategy, which support our mission. And so we built our electronic medical records. This is one of the biggest challenges we had. It took us, a few years to really have our data clean. We have to put control mechanisms there, and we still have people that responsible to committees responsible for the data and data control to make it clear. Then we established also a very sophisticated clinical and research laboratory here. And we made collaboration and support from other labs in the countries, because technologically, thanks God, we have everything available in this country. We have with the anti-doping laboratory, we have with the forensic lab, with Hamad bin Khalifa University, with Sidra, with others. And we are one of the objectives of this symposium is also to build more collaboration internationally as well. And this is why the invitees are here. Maybe they are here in this the first time, but and then we established also a physiological laboratory. I don't think I've seen that before, but we thought, I come from sports medicine background, and we think the physical dimensions have to be there. And we build the capacity here to push people to take them to a maximum potential of their physical, not just the mental or social, but also the physiological dimensions of things. And we also have the functional MRI suits. Suite. So you will see all of this, possibly that those who went for a tour today and those who will see have seen this infrastructure in place. We're still going to build more, but it's there. You can't do something without an infrastructure in place and a system in place. Okay, IT department, we've been working with them to establish and they improve their capacity in artificial intelligent machine learning, because they need specific engineers into this. They've been taking courses. I think we had the head of our IT did a course in artificial intelligence, and then he just left us now after he learned. So, but that's the nature of management and nature of organizations. We started training staff as well. We started when we had the strategy. It was actually in this room that we brought all the who is who in this organization, and most of it is to explain to them what's our strategy, where we want to go, and then after that there's a continuous program of training for everybody, different department, different specialties, on how to go forward. So this one, as I said, the symposium here is, you're going to see we're going to showcase of some of our work, some of the outcomes. It's a platform for discussion and collaboration as well, wherever you are from, okay? And basically, this is the programs that we're going to be exposed to. When I finish, I had to limit what I was gonna say, because Professor Amin, He's going to speak after me, and he would have killed me if I stepped into his, because he sent me his presentation, said, please don't step into my arena. So he's going to talk about it. Professor Amin, I think they're going to introduce him, but he's, I know him for quite some time. And he's, you're going to see that it's going to, inshallah, give you, if you understand him, by the way. You know, French accents are sometimes difficult. Okay? And then we've got genomics, pharmacogenetics. You will see, you know, that people, Dr. Jatish, he's from Hamad bin Khalifa, and Dr. Minal Jaber, she's the director of our laboratory, and she was one that came here and set up the laboratory here. She's going to talk about pharmacogenetics. Then we're going to continue with MAT, which is the medically assisted treatment, and you will see people talking about it, guests from outside, and Dr. You know, what we are implementing here as well. And then you will see all this kind of program going on. I'm not going to take you through each one of them. And then you will, tomorrow, is that session for? Yeah, tomorrow we're going to start the comorbidity and novel challenges. And after that, we're going to talk about sports and SUDS, because I've been in sports, and we have Khalid here. He's the, you know, director of Aspetar as well. And we know that athletes also have a special requirements before they used to be taken to just and given similar to the rest, but no, they have a specific needs. We need to keep them fit. We need to keep them, you know, on the top of their games. They have a psychological requirement different. It's their livelihood, by the way, and it's really unique that even if they step one, I mean, we as individuals, we can fluctuate in our performance. They cannot. And they have this special requirement, and that's actually go more into this kind of personalized precision kind of medicine as well. Okay. We will talk about how do we measure, because that's important that you will be able to measure and see what's your outcomes and see how do you do that. So we'll have some talks about that. And then finally, which is tomorrow afternoon, our last session will be Dr. Khalifa is going to present Naufar, and we'll talk about the collaboration, potential collaboration with the outside world, let's say, and internally as well. And trying to have a session that we're going to sit down together, and, you know, we have a panel that we're going to discuss and see, okay, where do we go from here as well. So hopefully this will be useful to us, useful to our staff, and useful to anybody else, either here or outside, in the subject of precision medicine and in substance use disorders. So I hope you'll enjoy this, the next couple of days. Anything you need, the staff are here to support you guys. And enjoy Doha. You've never been here before. Don't hesitate to ask where to go, or you need support. We will be there for you guys. Thank you very much indeed.
Thank you, Professor Muhammad. The second presentation will be provided by Professor Amin Benyamina, and will offer a foundational perspective on precision medicine in the treatment of substance use disorders, with a comprehensive update of recent advancements and the future of individualized care in addiction. We are honored to have a Professor Amin Benyamina in our keynote speaker. He's an esteemed addiction psychiatrist and currently served as the head of Department of Psychiatry and Addictology at Paul Bruce APHP Hospital. Professor Benyamina is also the president of the French Federation of Addictology, with over 150 scientific publications to his name. His research focused on therapeutics, biomarkers in addiction psychiatry. We are privileged to have him with us today to share his expertise and insights. Please welcome Dr. Amin.
Thank you very much. First, I would like to sincerely thank to Professor Mohammed Al-Mahadid, a visionary man, and the entire of the family and the Naufar families with Annette, Jalal, Vidya. And I'm honored to begin this conference in the presence of Your Excellency, Mr. Mansour bin Ibrahim Al-Mahmoud, Ministry of Public Health. The theme of the precision medicine is of burning relevant. I would like to try to say a word about it. First, in security, a quick overview to explain this model of precision medicine. Using biomarkers could help to identify subgroups. You have seen it, drug suspender, poor prognosis, high risk of serious side effects, high risk group of disease. This is the basis of our research in psychiatry. The identification of a subgroup could help to stratify a cohort for adapting the care and improving treatment response. You have symptomatic treatment like antidepressant, antipsychotic, anxiolytics, and other. And we have a molecular analysis to help us to detection on biological subgroups. Like we can make treatment adapted to comorbidity, like dual diagnosis, big challenges for us. Repositioning of molecules, specific treatment development. Actually, in France, we have a trial with psychedelics, a novel target to treatment in addictions, and treatment as usual. The objective is to switch from a trial and error paradigm to prediction of the most effective drugs to adient to pills, the adient to pills. Pharmacogenetics can help to predict the drug's dosage and the risk of serious side effects. We can have clinical trial recruitment, drug administration, and we have a good responses, no responses, and adverse drug reactions. This is the base. After, with the pharmacogenetics test, we can standardize those adjustments, and we can risk of adverse drug reactions, and we have a good response in both group. Pharmacogenetics is already applied in clinicals. You have this example with cytochrome HLI systems. We have this in clinical EM, PM, or EM. Ultra-rapid metabolizer, extensive metabolizer, poor metabolizer, or intermediate metabolizer, a risk of severe side effects. And we have responded to increase dose, to normal dose, to reduce dosage, response to alternative medications. This is the reality now. This is the reality of clinical. Precision medicine could modify the way clinical trials are conducted in our research. You have this model. At the left, intervention control. You have general informative therapy, standard therapy, post hoc genetics screen. In left, you have outcomes assessment, and you have the same in the right. With genetic stratification, we have made, this is a picture, A framework of research in precision psychiatry is detection of genetic defect, preclinical model in vitro, and in vitro drug testing. This is now we have in our clinical and research team. We have a patient DNA, next generation sequencing, disease modeling, and after we personalized medicine in the practice of medicine in the chance for candidate treatment to move from phase 1 to approval is twice when there is genetic rationale. This article in Nature Genetics, and you see, actually we use the GWAS and to show us the direction. You can see this, the FDA approved drugs were supported by human genetics evidence. This is our actuality, supporting human genetics evidence for new drugs approved by FDA in 2021. Oncology, other indication, no human targets. I think it's for our challenges in addiction is to make a direction to create a therapy, to create medication, a right medication for the right time, for the right person, but it lacks medication in addiction. I want to show you this big project in France, PEPR PROPSY, Precision Medicine in Psychiatry, and we began our inclusion this year, and psychosis, bipolar disorder, recurrent depressive episodes, and we have add addiction in the next year. This is a quick overview for about psychiatry. Then in addictology, what is an addictology? Addiction as highly polymorphic patients differ in terms of addiction severity, impulsivity, and associated psychiatric and somatic disorders. It's complex. Some individuals do not respond to treatment. It is therefore necessary to tailor treatment to patients' characteristics based on phenotypic and potentially even criteria or even genetic criteria. We begin with treatment responses modulations by genetics. First, pharmacogenetics. An early study from the 1990 was among the first to show that the response to bromocriptine in reducing alcohol craving among alcohol-dependent patients was more effective in individuals carrying the E1 allele of the TEC1 polymorphism of the gene encoding the dopamine D2 receptor after 6 weeks of treatment. Another well-known study showed that OPR1 encoding the mu-opioid receptor, a functional polymorphism that alters the efficacy of naltrexone, affects the time to relapse in alcohol-dependent patients. Carriers of the G allele, aspartic acid of position 40, had significantly lower relapse rates compared to the no carriers. This was a retrospective study. This was a retrospective study which the analysis of relapse according to genetic status was conducted at the end of the trial. The results of this initial study on OPRME1 was not confirmed by subsequent research, including by the authors of the original study when they attempt to replicate their finding in a prospective trial. Another more recent study, this time focusing on polymorphism in the gene encoding of the GABA receptor subunit 1, showed that individuals with the CC genotype had significantly lower relapse rates compared to placebo group, a difference that was not observed in graph B among carriers of the G allele. Now, the treatment response moderations by basal level of alcohol consumption. We had read this paper with a colleague, and a recent review on GHB has showed that the efficacy of treatments is higher in patients consuming more alcohol at baseline. This study showed that there is a positive correlation between baseline alcohol intake and the response to acamprosate, naltrexone, and nalmefene in alcohol-dependent patients. Here again, another study in alcohol-dependent patients showing a positive correlations between the response to baclofen depending on baseline alcohol intake, thus revealing that heavy drinkers better response to baclofen. Now another, treatment response moderation by the ability to abstain before initiation of the treatment. Another window. Here another fact showing that the response to nalmefene is dependent upon the ability of patients to abstain or not 2 weeks before starting the treatment. It has been shown that only patients who are not able to maintain abstinence for 2 weeks before starting the treatment will display benefit on the reduction of alcohol intake induced by nalmefene. I open the third window. Treatment response, moderation by the phenotype, the typology. Kiefer and al. Found that acamprosate was particularly effective in patients with Lech type 1. This is the Lech typology. We have a 3 typology. Whereas naltrexone was more effective in patients with type 3 and type 4 typology. Here then are the results of acamprosate and naltrexone across the different subgroups. Kiefer and al. Found that acamprosate was particularly effective in patients with Lech type 1, whereas naltrexone was more effective in patients with types 3 and 4. Comparing the course of abstinence rates, acamprosate was mainly efficacious in patients with low baseline somatic distress, whereas naltrexone was effective especially in patients with high baseline depression. Baseline craving show predictive value. Applying Lech typological differentiation, acamprosate was shown to be mainly effective in type 1, whereas naltrexone revealed best treatment effects in type 3 and 4. Numerous studies have also investigated the response to naltrexone and acamprosate based on the type of craving. Relief craving appears to be more effectively reduced by acamprosate, whereas reward craving is more effectively reduced by naltrexone. Here we see the results showing that naltrexone is more effective in patients with reward craving in terms of return to any drinking. Here we see Now we are going to speak about, to show you the treatment responses, moderation by anxiety, craving, impulsivity, and positive family story of alcohol use disorder. Baclofen may be more effective in patients displaying in lifetime anxiety disorder. Predicting treatment response to naltrexone, the influence of craving on family history. This is the paper I present. Here we see that naltrexone is more effective in patients with higher baseline level of craving. Here we see that naltrexone is more effective in patients with greater family history for alcohol or alcoholism, parents, mother or father with alcohol use disorder, thus suggesting genetics factors. Also, very interesting study showing that personality traits such as impulsivity may moderate treatment response. Here with modafinil in alcohol-dependent patients and the response of modafinil that may be changed depending on the level of impulsivity or of patients. We see, we showed on the left that modafinil is more effective in patients with higher impulsivity at baseline. And on the right, we see that on the contrary, patients with low level of impulsivity at baseline are not good responder because they have less of abstinence day. Now, treatment responses moderation by brain reactivity to alcohol cues. Can you use the alcohol cue? Can use the alcohol cue reactivity assist in brain imaging study to predict the response to naltrexone? I think it's a very interesting question. And the answer is yes for naltrexone. High alcohol cues reactivity is the ventral striatum is predictive of a good response to naltrexone higher number of days until severe relapse in the fMRI. And the effect of acamprosate is not significant, thus high alcohol cues reactivity is predictive of the response to naltrexone, but not to acamprosate. And now we're exploring the sex differences, gender differences. A very important question is also about sex and gender. We do not know so far if treatments of alcohol use disorder are effective in women compared to men, mainly because we usually do not have enough women in alcohol clinical trials. A recent study investigated the effect of sex-gender influence on the response to baclofen in patients with alcohol use disorder. Men tend to better respond to higher doses of baclofen compared to low doses in terms of both heavy drinking days and abstinence days. On the contrary, women tend to better respond to the low dose of baclofen in terms of both heavy drinking days and abstinence days. These findings support the hypothesis that baclofen has efficacy in alcohol use disorder and suggest that dose and sex disorder explores as potential moderators of baclofen response and tolerability. I choose the alcohol model to explain the precision medicine and addictology because we haven't a lot of research trial in other drugs. We have just a little information about buprenorphine, the responder of buprenorphine of methadone. In alcohol, we have much fact, much articles and findings. In conclusion, craving is a central aspect of alcohol dependence. Given the heterogeneity of patients, treatment should be individual. Genetics and phenotype phenotypic criteria can guide therapeutic decision, our therapeutic decision. I want to finish my presentation to show you our hospital, our services in the south of Paris. This is Paul Brousse Hospital. You are welcome. Thank you very much.
Thank you, Professor Amin. It's been an interesting morning so far. Please enjoy a 30 minutes coffee break until 11:50. Please return on time. حياكم الله. Excuse me, please come back by 11:40, please. Thank you.
Hello. Can you hear me okay? Hello. Can you hear me okay? Yes, good. Okay.
Welcome back, everyone. Now it's time for our second session, Genomics and Pharmacogenetics, a truly exciting dive into a science of genes and drugs. Please join me in welcoming our moderators, Mr. Naveed, Dr. Naveed from Naufar, Manager Pharmacy, and Professor Vidya Muhammad Ali from UCL ADLQ, who will guide us through this session. There are interpretations devices for those who want to use them. Thank you.
Thank you, Sam, for that introduction. So we will start with our first presentation. I would like to introduce Dr. Jitesh. Dr. Jitesh is the Associate Dean for Education at the College of Health Science at Hamad bin Khalifa University. Dr. Jitesh holds a master's degree in microbiology and has a PhD in bioinformatics from Queen's University. He has over 25 years of research and development experience in bioinformatics and computational biology at several prestigious institutions in India, Qatar, and the United Kingdom. In 2022, he was elected as a Fellow of the Royal Society of Biology. Dr. Jitesh's research focuses on bioinformatics and computational biology tool development and applications in translational research, pharmacogenomics for the prediction of response and toxicology to drugs, identification of causal variations in rare and complex genetic diseases, and machine learning and data science towards the implementation of precision health. Before moving to Qatar, Dr. Jitesh was the head of bioinformatics for the Oxford Translational Molecular Diagnostics Center at the University of Oxford and held honorary appointments with the Wellcome Center for Human Genetics at the Oxford University Hospital NHS Trust. Please join us in welcoming Dr. Jitesh to this stage. Thank you.
Thank you, Dr. Naveed, for the great introduction, elaborate introduction. Thank you for that. I would also like to thank Professor Al-Madid and Professor Vidya Muhammad Ali for this invitation. So to start, I don't have any disclosures to make. So let's start with pharmacogenomics. So far, the scene has been set by Professor Al-Madid and Professor Amin on pharmacogenomics, so I don't have to explain a lot, but just to give an idea that when we have a particular disease condition, we go to the doctor and then we get a diagnosis and prescription of medication. And then if you take a cohort of patients, you can see that not all of them are benefiting from them, and you have these different categories here actually. So for example, some of them will have some toxic adverse effects of the drug, but then they will have some beneficial effects as well. So in those cases, probably you may have to change the dosage to adjust to their levels of metabolism. And then in other cases, the drug is toxic and it's not beneficial, which means actually they should not be getting this medication at all. The other group is where the the drug is not toxic, but it is not beneficial either. So in those cases, well, sometimes they get some benefit because of the placebo effect. Okay, so the last category where the drug is not toxic and is beneficial, that is the category of patients who should be getting the medication. So all the other categories should not be really getting the medication, or there should be some change in the dosage. So that's all this variability is because of various factors, such as the pathogenesis itself and the severity of the disease that's being treated. Also, there is the several drugs given at the same time. There are some interactions between the drugs. Then you have the individual characteristics like their age, gender, the lifestyle, nutritional factors, their kidney and liver function. So all these can affect, and then this variability can happen. But the one which is of our interest is genetic variance. So genetic variation is where we talk about pharmacogenomics. Pharmacogenomics so studies this genetic variation affecting response to medications. It may be efficacy or it can be safety of the medication. And then when we want to study genetic variation in a population, of course, there is population genetics tools available now, so you need to recruit a cohort of patients or even healthy individuals and then start from there to understand what is the distribution of this genetic variance in different populations. So to do that, people have been working on this for years now, and then we know that the majority of such cohorts are coming from European populations. So there is kind of an underrepresentation of other populations. That's where, this is actually showing the how many genome-wide association studies have been conducted in the world, and you can see that majority are the European, and then there are some from the East Asian population. Same thing with the pharmacogenomics, actually. This is taken from pharmacogenomics knowledge base, or PharmGKB, where you can see that the distribution of the studies that are conducted in pharmacogenomics is, again, majority are in European populations, and then some have been conducted in East Asians, but the rest of the world populations are not very well represented in this. So that's why we have Qatar Genome Program, which is trying to establish the genomic landscape. To understand the genomic landscape, there is whole genome sequencing that has been conducted on participants who volunteered to join this program through Qatar Biobank. And so these are, this started in 2015, and research consortium, the QGP Research Consortium, was launched in 2017. I was fortunate to be selected as the leader for the pharmacogenomics stream of the Qatar Genome Program Research Consortium then. So I started working on it, but then, of course, you can see that the genome sequencing has continued. Of course, we haven't reached 100,000 yet. It's around 40,000 currently, but the availability, I'll show you the availability of the genome sequences. The phase 1, we had access to more than 6,000 whole genomes. Phase 2, we had more than 14,000, and the phase 3, I got access just last week for about 24,000 plus whole genomes. So this is the data set. And now when we looked at the initial phase of analysis, so there were about 6,218 whole genomes or samples from the Qatar Biobank. And it's not just the whole genome sequencing, there are like quite a lot of parameters, the phenotypic parameters that were collected, including age, sex, anthropometric measurements, a lot of lab measurements, self-reported questionnaire data on health outcomes, lifestyle, diet, and also on medications. And the whole genome sequencing data we used to extract various variants, genetic variants within that data, like the single nucleotide variants, insertion, deletions, copy number variants, structural variants. And after filtering, in this case, we had about 6,045 samples that were left for analysis. Another project within the QGP Research Consortium looked at what is the population structure of the Qatari population. And then it was found that within the Qatari population, the samples that were collected, there are kind of distinct groups, like, for example, the Peninsular Arabs, which are kind of the more Qatari origin, and then the general Arabs, and then there is the West Eurasian Persian, as you can see that from, they all closely aligned with some of these other populations. Then there are African ancestry, and then South Asian, then there are also admixed ancestry as well, population as well. So then we looked at how we can understand the pharmacogenomics from this population scale data. And in this case, we, as I said, we started with the 6,000 plus whole genome sequencing, but also we looked at what is the knowledge, current knowledge available in the pharmacogenomics field, looking at the pharmacogenomics knowledge base, or PharmGKB, and selecting all the variants that are known to be associated with response to any medication. And then we looked at around 2,600 plus variants in more than 1,000 genes. And then we found that the allele frequencies of more than 1,000 variants in 700 plus genes affecting close to 300 drugs or classes of drugs were significantly different between the Qatari population and the other world populations. Okay, so that's the first analysis we did. And then we found that actually even more than 600 variants had higher frequencies in the Qatari population. Okay, to look further actually, what is more relevant clinically, so we looked at pharmacogenes with clinical guidelines available. In this case, there is a consortium called Clinical Pharmacogenetic Implementation Consortium, CPIC, which has been curating this information about which specific gene drug combinations have more evidence that we can use in the clinics, and they also provide guidelines on how to implement this. If there is a genetic test that is done, how to implement it in the clinic so that the doctor can use or the pharmacist can use this information to make a decision on the prescription. So we looked at that time 17 genes with this evidence affecting 48 drugs. And then we found that, okay, within this 17 genes, we can find that within the Qatari population, there are variants which are already known, which is present in various databases like the DB-SNP, NOMAD, and Greater Middle Eastern Variome dataset. But there are variants which are very specific or population-specific as well. Okay, and from that we started looking at, can we look at not just individual variants, how these variants actually, in the case of highly polymorphic genes, especially like cytochrome P450 enzymes, the genes that code for these enzymes, they are highly polymorphic. So they are not the effect or the phenotypic effect or the status of their the metabolizer status is not actually determined by individual variants. These are decided by a combination of different variants within the gene. So we started looking at, can we look at all this together? And then we developed this bioinformatics pipeline actually to generate the reports for drug-wise or phenotype-wise or gene-wise, starting from the combination of these variants as haplotypes, and then, so these haplotypes, in pharmacogenomics terminology, we call them star alleles because we always say, for example, CYP2C9 is the gene, so CYP2C9 star 1 or star 2, that way, which will be different combinations of these variants. And then from these haplotypes, we then identified the diplotypes, which are like from the 2 homologous chromosomes that we have. And from the diplotype, there is a translation that is available from the CPIC, for example, to understand what will be the metabolizer status. And then based on these metabolizer status, they have also given this information about how do you implement this in the electronic health record? What would be the priority that need to be given? For example, if there is, there are cases where the genotypes or diplotypes have what they call abnormal or priority or high risk based on the phenotype or the metabolizer status, based on the prediction from their diplotype, then they can be considered, we consider them as actionable diplotypes, basically. So which means actually if a patient has an actionable variant, a drug or class of drugs may not be given to the patient, or dosage of the medication has to be adjusted. So that's what we call actionability. So when we looked at this, for example, I'm just giving some examples. This is not probably related to addiction or other kind of medications that are used, but to give some examples. And this is very interesting because SLC01B1 is actually a gene which can lead to adverse drug reactions when patient is taking statins, especially simvastatin. So in this case, it can lead to skeletal muscle toxicity like myopathy. And what we observed in the Qatari population is that there are, like the diplotypes, there are about 60 different diplotypes in the Qatari population. And if you look at these different subpopulations I mentioned within the Qatari population, we can see that the Peninsular Arabs have the highest frequency of these actionable variants, which means the potential for developing the muscle weakness or myopathy is quite high in this group of patients or in this group of individuals. Okay, and we looked at warfarin, it's a very commonly used oral anticoagulant worldwide and used in venous thromboembolism, atrial fibrillation. And the problem with warfarin is its narrow therapeutic range. So you can see that the international normalized ratio, which is determined by the dosage given. If it falls below 1.8, there is an increased risk of stroke, whereas if it goes above a certain point, there is increased risk of intracranial hemorrhage. So it has to be within that window. And of course, we know that there are genes which affect the dosage, like, for example, CYP2C9 and VKORC1. The CYP2C9 is the pharmacokinetic gene, and this VKORC1 is the pharmacodynamic gene. So when we looked at the dosing of warfarin, of course, with the CPIC has given this kind of a guideline. So if you have the genotype information available for VKORC1 and CYP2C9, then if they are non-African ancestry, there is clear evidence that the patients need to be given the dosage adjusted based on pharmacogenetics-based algorithm. Okay, so this is where this information is available. And of course, for African ancestry, as you can see, it's not like the European or other populations. They need to be tested for additional variants in CYP2C9. Okay, so and then there are these various. So if you look at this algorithm, what's on the right side, it can use actually all the information that is normally collected in the clinics, plus the genotyping information from VKORC1, CYP2C9, and also some algorithms can even use other genes as well. So what then we looked at how is this distribution between the European population and the Qatari population of the predicted dosage that we need to give every week for these individuals. And then we can see that the dosage requirement is a bit higher in the Qatari population compared to the European population. Then, of course, when we looked at all these different genes, as I mentioned earlier, we can see that on average, Qataris carry 3.6 actionable genotypes or diplotypes affecting 13 drugs with guidelines for clinical implementation, which means 99.5% of the individuals had at least one clinically actionable genotype or diplotype, which means actually anyone going to the clinic should have done their genotyping so that they will get a better prescription, so which will not lead to adverse effects, or which will lead to efficacious treatment. So now these are all the other genes I did not mention. So some of this, like CYP2B6, you can see it is different in the different compared to other populations from 1000 Genomes Project. These are different. Now, if you look at between the Qatari population of the European population, still there is actually difference between the distribution of these variants, which is significant, because what we want to do within the Qatari population, or we want to implement precision medicine genomics here. So we need to definitely be able to understand which specific genes we need to prioritize. So that's where this comes from. Now, we also looked at the Qatari subpopulations, and again you can see this is in comparison with the 1000 genomes, various superpopulations in 1000 genomes. There is a vast difference between the distribution of these variants which are actionable. And then even if you look at the QGP general Arabs versus peninsular Arabs that I mentioned earlier. So if you look at this distribution, still you can see that, of course, there are several genes in which this distribution of clinically actionable variants are quite similar. So that's why we can say that the study that we are doing can be extended or extrapolated to the other populations within the Middle East. Okay, but then there are certain other cases, like CYP2B6, for example, is different between the general Arab population and the Qatari peninsular Arabs. So once we have done this, we also looked at we did another project looking at the prescription pattern of psychotropic medications. Okay, this was a separate project. So in this case, we found that the prescription pattern of antidepressants in the Hamad Medical Corporation and Primary Healthcare Corporation hospitals for the 2 years time, this is between 2018 and 2020, we found that, of course, escitalopram is the one which is highly prescribed, and followed by duloxetine, amitriptyline, mirtazapine. So this is actually, we are looking at the prescribing pattern in the whole of the hospitals, okay, not specific to mental health diseases. We also did that. So we looked at mental health hospital, mental health clinics, and then what is the kind of prescribing pattern for those 2 years. So you can see that escitalopram is still on top, but then there is metazapine as the second. So duloxetine and amitriptyline have kind of gone out of this. So where have they gone actually? So we looked at what are the diagnostic indications that these particular medications were prescribed, and we can see that the majority of duloxetine was prescribed for non-mental health diseases, likewise amitriptyline as well. Okay, and then these are the different diagnostic indications, mainly like depression, anxiety, insomnia, but there are conditions where like adjustment disorder, dependence disorder, so they are prescribed for all these conditions. So this is for antidepressants. We also looked at antipsychotics the same way, and then we can see that in this case, quetiapine, olanzapine, prochlorperazine, and risperidone. These are the top kind of prescribing medications for or antipsychotics in the general hospitals. And in the mental health hospitals, you can see that in this case, quetiapine is still the top, but then olanzapine is the second, but then prochlorperazine is actually not there because they are not mainly used for mental health conditions, but they are used for other purposes. So you can see from this the plot on the left side. And these are the diagnostic indications of for the mental health diseases like depression, schizophrenia, anxiety, but there are various other things like dependence disorders as well. Now, when we looked at this, we thought, okay, we need to probably specifically look at the Qatar genome data again and see what is the distribution of the genetic variants that affect response to these medications, psychotropics in specifically. So in this case, by then we have received the 14,000 plus whole genome sequencing data, so we could look at this with a fresh look. And in this we focused, as I said, on genes influencing psychotropic medication responses and with clinical guidelines from one of these consortia, like the CPIC I've already mentioned. DPWG is the Dutch Pharmacogenetic Working Group. So we looked at these guidelines available, and there are 4 genes which have these guidelines available: CYP2C19, CYP2D6, CYP2B6, CYP3A for all pharmacokinetic genes, enzymes which are involved in the metabolism of psychotropics. And we looked at the frequency of actionable genetic variants, and we found that this varies between, in the case of different antidepressants, it's like about from 1% to 58%. In the case of antipsychotics, it was like 0.1% to 33%. So these are for various medications. So I can give some examples here. For example, selective serotonin reuptake inhibitors, or SSRIs. We can see that in the case of citalopram, escitalopram, the ultra-rapid metabolizer, you can see that it's based on CYP2C19. CYP2C19 ultra-rapid metabolizers are about 6.7% in the Qatari population compared to the 1,000 genome population, which is half of it. So there is quite a lot of ultra-rapid metabolizers. Rapid metabolizer status is also quite high in this population. So that's why these are all actually ultra-rapid, poor metabolizer, rapid metabolizer, and intermediate metabolizer. All these are actually actionable. That's why you get frequency about 58%. But of course, overall, it is not much different. Another drug, SSRI, is fluvoxamine. In this case, we have only evidence to say that poor metabolizers affect the response to medication. So in this case, we have about the poor metabolizer about 1.2% and 3% in the overall other population. So there is a kind of huge difference between the two. Similarly, paroxetine, there is ultra-rapid metabolizer, poor metabolizer, and intermediate metabolizer. Now, sertraline, in the case of sertraline, actually 2 genes contribute to they are involved, or 2 different enzymes, CYP2C19 and CYP2B6. These 2 enzymes are involved in the metabolism of sertraline. So in this case, we have looked at the diplotypes of both the genes together, and then we found, so we have these different recommendations as well. For example, if somebody falls with a diplotype falls in this category of A here, they start with recommended dose, but then they need to titrate to a higher maintenance dose, or they need to be given alternate antidepressants which are not metabolized by CYP2C19 or CYP2B6. So these kind of different recommendations are available. So we looked at how how is this distributed within the population. So we can see that they are kind of comparable with other populations as well in the case of sertraline. But when we looked at tricyclic antidepressants, so this is the kind of chart where we have CYP2C19 ultra-rapid metabolizer and CYP2D6 in this case, how they actually contribute to the response. So from this, we generated these charts again, looking at these 14,000 plus whole genomes. And then you can see that in this case, A is to avoid amitriptyline use. So this is actually A, and B actually is to consider alternate drug not metabolized by CYP2C19. This has a drastic difference between the recommendations that we need to give to the clinicians. So in the case of other populations, probably they can have an alternate drug, they can have a dosage change, but in the case of Qatari population, majority of them would need an alternate drug rather than tricyclic antidepressant. And also we looked at antipsychotics, like there is as I said, the Dutch Pharmacogenetic Working Group guideline for risperidone and CYP2D6. And again, you can see that the distribution in some of these cases are different from other populations for the clinically actionable variants or diplotypes. Okay, so to conclude, the pharmacogenomic landscape, we studied the pharmacogenomic landscape of the Qatari population, and we see that the Qatari population has a distinct distribution of genotype or diplotype frequency for several clinically actionable genes associated with response to common drugs. And the frequency, as I've seen, as I've mentioned earlier, 1 to 58% for antidepressants, 0.1 to 33% for antipsychotics. And also the Qatari subpopulations also show distinct frequency distribution. And understanding these actionable diplotype frequencies will help in the prioritization of gene-drug pairs for clinical implementation in Qatar. And if we generate reports for these individuals, which we already have this information, which can be implemented in the electronic health record system, and the doctor or pharmacist can directly use this information anytime, because these genotypes are not going to change during your lifetime. Okay, this will help in preemptive implementation of pharmacogenomics. So I mentioned about some of these papers. This is the major paper that we published in 2022, which has been now cited a large number of times, many times, but also this has been the base for implementation strategies in the HMC for pharmacogenomics. And this paper has been just accepted in Cambridge Prisms. I mentioned about the antidepressants and antipsychotics. And I would like to acknowledge the Qatar Precision Health Institute, previously Qatar Biobank and Qatar Genome Program for providing the data and the opportunity to work on that. Sidra Medicine, where I worked previously, the Hamad bin Khalifa University, where I work now, and also all these different consortium worldwide. Also, some of the collaborators, Sir Munir Pir Mohammed from University of Liverpool, Suhail Agulum, Waqar Azim from HMC and Sidra, Xavier Estival, a previous mentor. Thank you. Yes.
Hi, Jitesh. Fantastic presentation. Thank you so much. Really grateful. I had a question. I found it slightly incongruous that so little had been done in sort of the global south, and the majority of the sequencing has been done in the global north. This, I mean, when you look at sort of pharmaceutical research, etc., is the other way around. A lot of it happens in the global south. Is there, in your expert opinion, any reason why the global south hasn't been sequenced?
And I think it's mainly the priorities and the kind of resources available. And majority of the cases, these are looking at the population once the drug has been in the marketplace. So this is where most of these studies are done. So at that point, actually, majority of the population just go with whatever we have, and then the trial and error method that Professor Al-Mahdi earlier mentioned. So it's like kind of you just need to give the medication and see whether it works or not. So that kind of an approach has been there, but the more systematic kind of analysis has been happening in the north. That's probably the reason.
Thank you sincerely. What an inspirational presentation, and what an asset you have from this work that's bearing fruit already. And I guess I had an addiction eye on this wonderful presentation. And what caught my eye, and educate me if I've summarized in my head, but I think I'm right that the CYP2B6 is involved in nicotine metabolism. And I think I'm right in thinking that there's a relatively high prevalence of smoking among Qatari males. And please knock me back if I'm wrong on that. And I just wondered if that opens up a line of thinking about risk of nicotine dependence, but also possibly targeted varenicline and behavioral support and nicotine agonists that might be targeted through a genetic assessment.
Absolutely right. So now we have this data available. This can be used for various purposes, actually. So we can specifically look at nicotine addiction, or it can be for any other substance use, actually, disorders. So it is possible to look at these, and because we have done the kind of preliminary work, it's just a matter of extrapolating it to the specific drug or the disease condition. Yes, thank you for the question.
Yeah, I'd like to also congratulate you on this this excellent presentation. One question that really comes into my mind is, and I think it applies to all the presentations, is how would you incorporate this knowledge into the daily practice?
So that's a very good question, actually. So as we have seen in several parts of the world, mainly in the US and those parts of the world, actually, the information that is available about the genes I mentioned, and plus some more, actually, so which is not in this, they don't have a clinical guidelines from the consortium yet, but still those genes are genotyped before medication is given, actually, in several hospitals. So this is what we want to achieve in Qatar as well. That's why the program has been started in Hamad Medical Corporation, where there are studies on warfarin, statin, clopidogrel. All these have a lot of evidence. So this is happening right now, and in the cancer field as well. So hoping that this will soon be able to. The other component that we have on here is the local kind of rare variants or non-variants within the Qatari population, which we need to account for. So far, we are just working with the information available from other populations. So for this purpose, we need to do the clinical trial kind of studies, clinical trials for understanding any specific variants which will be responsible for the response or adverse reactions.
Sorry, can I? Excellent presentation, and I can see these girls saying to me, no more questions, but I'll steal one question. You're getting all your guidelines from CPIC.
Yes.
How useful is CPIC? How relevant is CPIC to this population? That you've already said, and we know this in almost everything else, but if we use that, then how do you know that these predicted variabilities actually flow through into practice? And as Jalal, you just mentioned, can we use those guidelines that are mainly brought from Europe?
From the European population, yes, I understand. So of course, we need to start from somewhere, and it's kind of the starting point, actually. So if we start from here, we understand that actually when we implement this, we will still see this difference. So even though we are implementing genotyping in the clinic, we might end up seeing actually some patients are still not benefiting. That's where we need to have a kind of targeted trial and then see that actually what is different, what are those specific variants which are affecting this population. And then that can be used for the setting up guideline for clinical implementation in Qatar.
Thank you, Dr.
Thank you very much. Yes.
Okay, next up we'll have Dr. Manira Al-Jaber. She is the Director of Laboratory at the Anti-Doping Lab in Qatar, where she also serves as a leading figure in research, scientific strategy, and innovation. With over 15 years of multidisciplinary experience, she has established herself as a prominent voice in the fields of anti-doping science, substance use research, and genomics. She holds a PhD in cellular and molecular medicine from the University of Bristol. Her time in ADLQ has been marked by a focus on integrating genomic approaches into doping detection and exploring molecular biomarkers related to substance use and performance enhancement. Previously, Dr. Al-Jaber also served as a head of laboratory here at Naufar. Her work here further deepened her expertise in clinical toxicology and addiction science. As the director of laboratory at ADLQ, she continues to lead innovative projects at the intersection of sports science, public health, and molecular medicine. Please join us in welcoming Dr. Moneta.
Thank you. Thank you, Dr. Naveed, for the thoughtful introduction. And thank you for your time. Thank you for the organizers for inviting me to speak. I will talk about pharmacogenetics and SUDS. Following my esteemed professors there, it made the job really easy to talk about what I want to show today. To disclose, I have no conflicts of interest to disclose. I will be talking about the background of pharmacogenetics in SUDS, some genes of interest which have been already touched upon by Professor Amin, translational examples and point-of-care testing in the genetic context, technology readiness, are we there, and our study and what we have conducted here in Naufar, and some conclusion and future remarks. Polymorphisms in genes encoding drug metabolizing enzymes, neurotransmitter receptors, and transporters influence pharmacodynamics and the kinetics of the drug. A better understanding of these may allow optimized treatment efficacy, reduce adverse effects on health, and improve retention in treatment programs. An individual's genetic profile can be used to select personalized and effective medicines to optimize patient treatment outcomes, which is pharmacogenetics. The classic treatment approach, the patients are presented to in the clinic, and these, the phenotypes are recorded to the physicians, and lab results are inputting into your treatment. What we want to see is more pharmacogenetics into the laboratory, into the clinical setting, where it can feed into the decision-making for clinicians, and starting seeing your patients as individuals with individualized needs according to their genotype, where doses can differ according to their genetic profile, either dosage or a totally different drug. And this was explained very nicely by Dr. Jijesh just before me. Some genes of interest have been already covered by Professor Amin, and these are of interest because they have a proven genetic effect, including OPRM1, which in relation to SUDS, this gene encodes the mu opioid receptor and has been of significant interest. It has this certain SNP that has been shown to alter receptor binding affinity and then downstream signaling. Individuals with the G allele may respond differently to opioid antagonists like naltrexone and demonstrate better outcomes with naltrexone therapy in alcohol use disorder, including reduced craving and relapse rates. Some other genes of interest include DRD2, COMT, and DAT1. These genes are related to dopamine transmission and of particularly of interest in treatment of stimulants and alcohol use disorder. Polymorphisms in DRD2, for example, have been associated in differences in dopamine receptor density, which can influence vulnerability to addiction and treatment responsiveness. It is also associated to specific type of alcoholism and may exhibit poorer outcomes with traditional therapies, but a greater responsiveness to dopaminergic agents or even behavioral interventions that motivate and reward sensitivity. The CYP54 family enzymes, which may touch on one of the questions from the audience, these are the family of enzymes. These are very big enzymes and very important ones that are located in the hepatocyte, mainly responsible for metabolizing over 50% of all clinically relevant drugs, not only those in relation to SUDS. So you can expect that a lot of these CYPs will pop up in any treatment approach. They are found mainly in liver, lower concentration in other places of the body. And due to this location, these enzymes play a significant role in the first pass of metabolism of all orally administered drugs. So any variants in this enzyme family significantly impact drug metabolism in SUDS treatment. Polymorphism in CYP2D6 affect the metabolism of methadone, buprenorphine, and certain antidepressants used in dual diagnosis scenarios, where you have mental health issues in addition to the substance use disorder. Ultra-rapid metabolizers may require higher doses to achieve therapeutic efficacy, where poor metabolizer may suffer from the risk of toxicity because you are increasing their dose and they have abundance of the drug in their system. Specific gene-drug interactions are beginning to enter clinical guidelines or decision support tools. These include CYP2D6 for methadone, CYP2B6 for bupropion, and OPRMN for naltrexone. In this 2020 review, they examined how the genetic variation influences patient responses to buprenorphine. Despite its effectiveness, buprenorphine clinical outcomes are highly variable, and it depends on what Professor Maadi just said, that there are a huge individual variabilities among individuals. Many studies failed aslan to demonstrate any differences, especially if in this paper they looked at the dropout rate as the endpoint and mean doses or mean of dose. Other studies, such as the one in the bracket there, enrolled African American patients in the US, and the finding demonstrated that nearly two-thirds of the patients, two-thirds of these patients during pharmacogenomic-based dosing period exceeded the labeled maximum daily dose, which I think may sound familiar to some clinicians in Naufar. This suggests polymorphisms in CYP3A4 and increased metabolic activity to buprenorphine. Entering the genetic point-of-care testing, traditionally, genetic testing have been undertaken using laboratory-based techniques, which are lengthy, logistically complex, and may require samples to be sent to diagnostic laboratories that may be in geographically far locations. In the context of genetic testing for rare and inherited diseases, which is the majority of the activity for genetic testing, this approach has not been problematic. As results are rarely required rapidly to inform treatment decisions. However, with the emergence of pharmacogenetics as a clinical entity, has led to the scenarios where results are required to guide the treatment in the acute clinical setting. And to address this unmet need, point-of-care testing devices have already been developed, and they are ready and validated, which are able to provide rapid patient genotype results for the management of time-critical conditions. Again, sorry. This technology have been developed already. SUDS is already, hopefully is catching up. So let me take you through how it could look like with this. This is one example for CYP2C19. This is a validated gene drive system where enzymes, CYP2C19 enzyme metabolizes the prodrug clopidogrel to the active metabolite, which selectively and irreversibly inhibits platelet aggregation. Loss of function variants for the gene are frequent in the population, where star alleles 2, 3, 4, and 35 are known to be loss of function alleles. And as humans, we have diplotypes, so you could have loss of function allele and another gain of function allele. As you can see in star allele 17, which is a gain of function. The wild type is star 1 allele that has normal functioning and reflects results where no loss or gain of function of variants have been identified. Again, this technology has been developed already, and you can see clearly that in this machine you can easily see the result represented on the screen of the machine. And this is to say that in a clinical setting, you can easily interpret results or pharmacogenetic results. As I said, humans have 2 alleles for CYP2C19 and other genes, and the combination of these alleles in diplotype define the individual's metabolizer rate. The presence of one loss of function allele in combination with a normal function allele results in the intermediate metabolizer status, and so on. In this study, they are looking to validate this exact point of care testing, where they have validated through participants of 204 patients. They used the system to ID their genetic makeup. They have a few failures there, and then few that were not concordant with the AGENA here. So they used the gene-drive system, and so only 2 tests have failed, and the results were obtained from 202. Then these were confirmed using the AGENA mass array system, which I will show you again what it looks like. And they have results that are concordant with the gene point of care testing in comparison to the AGENA mass array. And those that have failed, either failed or were not concordant, they went again to the gold standard, which is the Sanger sequencing, and have identified that their original result is actually accurate. So this tells you that this point of care is validated and accurate. So why is it important to look at each patient's genotype in the context of CYP2C19, ischemic stroke or transient ischemic stroke? Transient ischemic attack is what makes it important to look at CYP2C19, where the risk of, in these cases, of secondary event is highest in the first 90 days, and then it reduces afterwards. The risk of further stroke within the first week is substantial, highlighting the need to prompt an effective secondary prevention. The prescription of antiplatelet is key aspect of this management. There are already national and international guidance now recommends that CYP2C19 genotyping should be used to inform antiplatelet prescribing drug. So how is this relevant? As we said in the beginning, CYP enzyme family metabolizes many drugs, over 50% of all drugs. And these include blood thinners, such as the example we just saw for clopidogrel, and then some antidepressants, so which brings it back to contest in the NSAIDs, and to be used as a strong tool for prescribing decisions. All of this sounds really good, and to touch upon the framework that Professor Amin have provided for pharmacogenetics, we can say we have the questions, is the technology ready for such advances? Technology is there, has been developed, and we show even point-of-care testing has been validated. Are we prepared? I will let you be the judge of that after we talk about what we have conducted in our laboratories. So in order to see the genotyping results, there are many methods. Genotyping by PCR, this is most easy and maybe not labor-intensive as could be, and very little bioinformatics analysis needed. Genotyping, that's by PCR. We have the time of flight, which is the most recent, including the AGENA mass array, Sanger sequencing, which is an genotyping, which is the gold standard in this case. And again, the next generation sequencing, whole genome and whole exome sequencing. I will go through our protocol that we have used and utilized for our study that I will talk about in a minute. First, we need this critical information. To begin with, we have to have the good quality of DNA, good quantity, and then for any downstream activity. And this can be conducted in many systems, including the lab chip GX touch system that we have already set up in the lab. This is the picture from our laboratory, and this qualifies our sample to downstream applications. So now we have our DNA sample qualifying for any downstream application. We have many technologies to choose from. Again, this is another picture from our laboratory for real-time PCR system, the Quant Studio, which is a gold standard. It has the ability to do 384 samples and multiplexing capabilities, which means you can look at multiple SNPs within the same tube, within the same sample. So then you are targeting multiple SNPs within the same sample. Other applications includes microRNA profiling, which I will come back to in my last slide, so just keep it in mind. Another real-time PCR system that we already have in our laboratory is the VIA 7, again, a gold standard in PCR. These are very helpful in low throughput and multiplexing, and if you really know what SNP you are targeting. So you have to know what polymorphism you are looking at. The Agena mass array is ideal for high throughput context. Again, 384 with multiplex. And the Sanger sequencing, this is what I call my baby in my career. So sequencing, genotyping, it can do anything. It's the gold standard. It is the original technology used for the whole genome sequencing, and it is still used for both genotyping and sequencing. And as I said in the first slide, in 2020, they used this machine as the gold standard to identify which result among the discordant results was the correct one. Again, we come back to whole genome sequencing and whole exome sequencing. These are very exciting things for me, and this is where it's more or less like for a research setting where you are not targeting any specific polymorphisms. You are looking at the whole genome or the whole exome. Exome refers to the coding regions of DNA, and these are exons, and most genes lies within these exons. So the whole genome, whole exome sequencing will only look at the coding regions of the DNA. And these are all technologies that are ready, and we have them set up in the laboratory. This is the only method capable of identifying unknown SNPs. So if you would like to see, you notice something in your cohort and you think these are definitely different than the other patients, then this is what we need to do. And it is able to determine large number of SNPs from small amount of your input DNA. So if your sample is precious, this is the way to go, because that will create your library. And as Jitesh said, that DNA will never change. It's there, and you can always come back to it when more evidence pops up. So for us, we are locked in and ready to roll. All the framework for pharmacogenetics in SUDS and precision medicine are there. And I will show you now what we have done with these technologies at hand. With Naufar, we have data that were collected from patients' clinical records after huge efforts from our colleagues at Naufar, after receiving, of course, approval from Ministry of Public Health with the Registered Ethical Committee. Around over 700, let's say 800 patients following medication-assisted therapy program at Naufar in the period from 2020 to 2023 were recruited, and we collected 50 data points of clinical data were obtained and maintained in the project database. And then this was followed by PGX genotyping. This is our patient characteristics. Again, it's mainly males and young males between 21 to 30. And these are well described their phenotype, and then their presentation to the clinic is all recorded in our Qatar SADS Biobank QSB. So we utilize the pre-designed assay targeting highly relevant variants in 20 principal genes implicating in drug metabolism pathways. Again, this is the genome mass array that we use for the Naufar study. This provides genotype information for 68 variants, SNPs or single nucleotide polymorphisms, and inserts or deletions within 20 genes. This is the core panel used was called Veridose 1.1, and you can see it clicks most of our genes of interest that were described in previous presentations and in what I began my presentation with, including CYP3A4, DRD2, and OPRM1. Results. So now in our cohorts from almost 800 patients in Naufar, we have our first results on what the genotype looks like. I'm sorry about the font is too small. Let me see. So this is COMT, and the G allele in this COMT is associated with faster dopamine breakdown, which means you have lower dopamine in your levels very soon. I see a red card. I hope I'm not. This is the result. These are important. Sorry. Okay. So these are associated with low metabolizers, slow metabolizers. Diana, you threw me off. And now, sorry, I can't even see. It's very small. Yes. Okay. So now we have well characterized the Naufar patients, and these are all genes of interest where they have, as Jitesh said, actionable, I'm sorry, I can't find Jitesh, actionable genes. Again, these are very interesting, and these are all either slow metabolizer, fast metabolizers. And interestingly here, I think this is in the top, you can see CYP3A5, and the bottom here, CYP3A4, and these are also have, we are mostly loss of function for CYP3A5 as a Qatari population, while in CYP3A4 we have ultra metabolizers. So it seems like these genes are actually, subhanAllah, they are compensating for each other. We have some complex phenotypes or variants in the Qatari population where we don't see uniformity as much as CYP3A4. So this is our results for the Naufar study, and this is looking at the substance use patients' genotype. We also compared it to other cohorts in other populations. This was done in comparison to the 1000 Genome Project, and then we compared it also to Qatar Genome Project. So we have Qatari substance use patients against Qataris of non-substance users. So that result is very interesting. And we looked at it as a whole for the 1000 Genome, and then against Europeans within the 1000 Genome, and against Asians that are in the 1000 Genome. These are fresh off the press, as they say. These are I looked at it maybe yesterday only, but you can see that there are differences. These are adjusted p-values in comparing Naufar patients with the other populations from the 1000 genomes. What's interesting is that if you look here, you have Naufar versus Qatar Genome Projects. This is Qataris for SADS patients versus non-SADS patients. And you can see that there is a lot lower number of significance there in genes or allele frequencies. And even though they are not many, but I think these are of a huge interest because it may have more information to look at for susceptibility, let's say, and susceptibility. And then going back to someone said about the history of the patients and familial history. So all of these, inshallah, will be further analyzing, and we can tell you more about it in our articles. I will wrap up now. Tremendous advances are made in the field of genomics and SUDS. The technologies are rapid, and they are there and sensitive, and they have greater genome coverage, which was maybe 10 years ago, it was a problem. The combination of these technologies achieved success in benchtop assays, including quantification and analysis by informatics. And this is done in a large number of genes. Other clinical fields, such as cardiovascular and oncology, are already benefiting from this, but we are lagging for substance use disorders. Further work is still required to improve our understanding and functionality, validation of these tools and SUDS. Studies such as this one, the Naufar study, point to a future where precision addiction treatment is actually feasible. Quickly, I will go to what we can consider. So for the future, all of this talk is very interesting, and I love it very much because it's genetics. But it's all on the genetic makeup of each patient. We need to consider other things like what Professor Ma'adid mentioned, the epigenetic patterns, histone modifications within the DNA, and methylation. And there are studies that shows that there are methylation patterns that happens. Methylation is adding methyl group on top of that DNA strand, and then that gene cannot be transcribed. So even though your instrument says he's an ultra metabolizer, that methylation prevents the expression of that gene. So then there is these epigenetic patterns, including methylation. And microRNA, which are also post-translational problems for us, because they can also, even if the gene was transcribed, then the microRNA profiling, which I pointed out in our technology, can actually inhibit that protein from exerting any function. So then you have these, we come back to biomarkers, DNA-based biomarkers. Okay, sorry. I thought this was interesting. And then there is environmental factors that you can put into the context of precision medicine for individualized treatment. I would like to end with acknowledging His Excellency Professor Mohammed Al-Ma'adid for his support and making this project a reality. Professor Vidya Muhammad Ali, of course, from UCL, Dr. Khalifa Al-Kawari and Dr. Rama from Naufar, Dr. Chidam from Anti-Doping Lab, and of course, Dr. Chidesh from Hamad bin Khalifa University. And thank you for your attention.
See?
Thank you very much, Naira. It's terrific. Bravo. The sample of your studies is all addictions? All addictions? Alcohol, yes, the patients?
Yes, these are all patients in Naufar.
One question about COMT. You know the studies about psychosis and the marijuana. You know the studies of Caspi and about the allele show the possibility and the higher to become psychotic or schizophrenia with the when the allele was COMT. Do you have the same situation in your sample? No.
Again, we are just now analyzing the results, but for me, I look into alleles and genes, and I can tell you if it's a fast metabolizer and slow metabolizers. But for other, what we mentioned as dual diagnosis, then we have to take it to clinical practice. I think one more thing is I want to highlight is that all of these are, as Jitesh mentioned, is different according to farm GKB, which is mainly Caucasian population. So again, bringing it back to the clinical setting. We have this information, but are we providing it to our physicians? Not yet, because we need to validate all of these things.
Yes, it's important to return to practitioner and you show your phenotype.
Definitely.
With this, yes.
Sorry, just to add on to that, I mean, it's just come off. I think, Jitesh, we talked about it probably 48 hours ago. There is so many other things. We have to sit with Rama, for example, and really look at all of the other, the prescribing, the phenotype in more detail, like you've just mentioned. So I mean, it's just Munira got quite excited and insisted she's going to present it today.
Very excited.
Something I forgot to say when we were talking about the infrastructure. We are actually building a biobank here, you know. So we are really building our data bank, biobank. So we are really building that resources that's going to be there. And then we have this prospective follow-up of our patients and evaluations and putting in place, you know, measuring the impact and, you know, how are we going to and associate all this together. When we talk about this going to quantitative research, and this does not mean we left our qualitative, actually we are building on that. So just to, you know, things that it's coming up, and as I said, we are 2-3 years now from, and it's been, really we just want to see that we are on the first steps, that on a solid ground, and we continue from here.
With IA, it's fantastic.
Yeah. Yeah. And that's, I think, where you want to succeed. It's not a program. It's an infrastructure. It becomes a part of your DNA, part of your culture, part of how you practice, how your staff think about it, and this kind of thing. Thank you.
Thank you. Thank you so much.
Thank you so much to our speakers and moderators. Lunch is now served. We have 1 hour, so 1:50 inshallah. Enjoy your lunch. Welcome back, everyone. I hope you had a great lunch. Now, we are ready to dive into session 3, medical assistant treatment. Let's give a warm welcome to our moderators, Dr. Ramzi Haddad, Senior Consultant, Psychiatrist, and Directed Care Lead, and Dr. Shahid, Family Physician from Naufar, who are here to guide us through this session.
Thank you, Issam. I have the great pleasure and honor to introduce Professor Alexander Baldacchino, Clinical Professor at the University of St. Andrews School of Medicine. Professor Baldacchino is Executive Board Member and immediate past President of the International Society of Addiction Medicine. He's Chair in the World Psychiatric Association Addiction Psychiatry section. He is also Scientific Advisor for the European Union Drug Agency and the World Health Organization, and also founding member of the European Network for Treatment, Education, and Prevention Mental Health section. Professor Baldacchino is the author of a very large number of scientific peer-reviewed articles. He is specifically interested in utilizing informative technology, clinical outcome data, neuroimaging, neuropsychological processes to identify and minimize the risk of substance use disorder. Professor Baldacchino's topic today will be on the use of innovative technology in reducing drug deaths, and so the potential use of precision addiction medicine to save lives. Thank you, Professor Baldacchino.
Thank you very much. I am very impressed, truly impressed. Not only that you said my surname properly, but you managed to get all those acronyms, proper. I'm really, really impressed. Hello, everyone. Thank you very much. I'm really, really honored that you've invited me over for the second Congress for Naufar. And I'm really excited to share with you these experiences that our lab, our research team at St. Andrews University have been involved in. Hopefully changing the way we think about certain things, but most important, that we're able in the future, near future, able to save lives. And I think that's the most important bit, the most important message in all of this. So, when I was invited, I thought, okay, so which elements should I take and present? My lab deals with different types of portfolios, but I thought this was pertinent. And when I was listening to the introductions this morning, I was relieved actually to, say, okay, this is very important what I'm going to say, because this is going to add value to the presentations this morning and later on. So I have no conflicts of interest. First, my presentations are usually based on messages. Yeah, there's some detail, but important message, take-home messages. So even if after lunch you feel a bit tired, please listen to this first message. Is that this is where we are in Scotland compared to the US, which, as you very well know, there is an opioid epidemic, and the rest of Europe. The first one is about deaths as a result of substance use disorder. And as you can see, the rise in Scotland is equitable to that one in the US. But the message is, and we know in Scotland we are outliers to the rest of Europe, and we still don't know why this is happening. Now, you might be saying, oh, this is not Scotland. This is Qatar, where we don't have any drug deaths. But I think what's important here is to think outside the box, because people do not fit into the boxes that we want them to fit. Yeah? So when you look at the statistics here, I've put in statistics of alcohol-related deaths, statistics of suicide deaths. And one needs to think about when, you know, I've worked for 6 months in Cairo with the WHO, and when you ask people and say to countries and regions and ministers, they say, oh, no, we don't have an alcohol problem. Oh, no, we don't have a suicide. And I've asked that question this morning, and that's the response I got. But the message is, think about other types of data that is out there which would give you a better representation. In Scotland, we have around 3,000 individuals who are dying every year as a result of drug deaths, alcohol deaths, and suicide. And the government still does not think that's a public health emergency. That's the message, by the way. And this is the profile. This is, you know, years and years, 20 years of collecting data where we know what the cocktail of drugs are, predominantly sedatives. We know that that constitutes mostly of opioids, alcohol, and benzodiazepam use. And, you know, we were the first to institute harm reduction, overdose prevention techniques using the opioid antagonist, Narcan, in the world, actually, where it was mandatory to give to families, to non-clinical environments to hand over this aspect. But still, drug deaths are still going up. So we need to think outside the box. And I thought about, you know, as a context is, look, the technology is there. You know, we talked about pharmacogenetics, but there is also technology that we can utilize in order to enhance the prospects of providing a system that is responsive and also able to make a difference. So we talk about, you know, digital health, like all sorts of different apps for recovery purposes, pharmacological and pharmaceutical delivery systems that can be used. You know, one good example is the long-acting Buprenorphine, which, of course, has changed the way patients comply with services and equally how services are able to support individuals. Biotechnology, neuroscience, neurostimulation, we're going to hear Hamed talk about that later on. Behavior, CBT integrated with artificial intelligence, virtual reality, augment-related blockchain for patient data, which would support and enhance the prospect of confidential information governance frameworks, behavioral economics, cryptocurrency-based awards for contingency management, digitalized integrated care, and delivery systems, such as utilizing drones, which we have experimented a wee bit in Scotland, in the rural areas. But I'm going to focus and concentrate on 3 elements. How do you create innovative services? You know, we're all trying to invest and sustain in creating a service, but how are you able to then move on to innovative services, innovative data collection, and innovative technology, which we believe, I mean, not we, just in St. Andrews, but in Scotland and the UK, we believe would support some elements to reduce morbidity and mortality in the patient population. So if we move on to systems and implementation science, so this is another way. It is not about my opinion or someone else's opinion, but using science in order to support systems. Science in order to support the implementation of those type of systems. Now, I put this here just as a bit of to shock people, yeah? And focus people's attention. Because, of course, you cannot read it, yeah? But this is the reality. This is what clinicians, what service providers, policies grapple with. We are talking about providing a service, reducing morbidity, mortality. This is the system. This is where these people live in, experience support. And I'm going to introduce something which you all heard of, but none of us, I'm pretty sure, are trained for. We're talking here of not just a vulnerable population, stigmatized population, but we're talking here of a complex system. This is not a parallel system, A to B to C. Yeah, this is 3-4 dimensional system. These things don't just happen and stay there with time. They move. every patient. Personalized medicine, and you mentioned, the right treatment, right setting the right treatment for the right patient, something like that. Yeah, that's very challenging when you have time as well into this. Yeah, how responsive are you? So you need to understand and embrace complexity. And research and work that we've put in with the support of the European Union and the Scottish Government, we're trying to sort of utilize this way of thinking in order to establish a telemedicine opioid use disorder system, which would complement the conventional, traditional, face-to-face type of systems. But we're using that in order to then, by reverse psychology, also identify what type of implementation and new systems can be used to conventional systems. So when we looked at this thing, these are the take-home messages. Another message is we need to have an inclusive health focus, and we were talking during lunch how important it is that we talk here of addiction medicine and addiction care, which is compassionate, but also evidence-based. This is not about addiction psychiatry or, addiction specialists, etc. Everyone's responsibility. So it needs to have inclusive physical and psychological health focus. Transitions through care. We need to understand that there is no one simple, straightforward transition, that there are several different pathways, entry and exits. Complexity of the care needs, as I explained, increasing service surveillance. And you have such an opportunity with the ability to collect data. The challenge is, the more data you collect, the better you need to be to maintain it, but also to interpret it, so that you start having life intelligence. Yeah? What tends to happen, the more data you get, the longer it takes for that data to come back to service providers in order to be able to change things. Multi-agency, definitely. Digitally enabled workforce, and stigma reduction. And this is, some of the work we looked at in order to say, okay, so what does telemedicine opioid use disorder service means? Intuitively, it makes sense. Yeah, online, telephone or using the systems, the media that's available there. But I think it's more than that. So we decided to explore this using co-production and co-design. I don't know if those are words that you utilize here. That means with the patients, with the family, understanding better what that means. Everyone carries a mobile phone, but we differently operate the phone in different ways, and we have anxieties, and we have all sorts of different platforms to use. So we need to understand how well they're able to use this type of mechanism. But it's going back here. It's engage, empower, yes, but also embrace complexity. I'm sorry, I'm sort of perhaps repeating myself. But this is an article freely available in the Lancet. And this is around, what are the key implementation factors when you set up a service of this nature? And you start exploring further, and as much as you try to be a reductionist, try to dig deep dives, but you also need to understand that there are different players who work in different ways. But it allowed us to understand what the risks are, negative, positive risks, what actually makes a system operate and be sustainable. And this is one of the framework that we were starting to adapt in order to encourage services to operate on a telemedicine platform. More work has been done on that, but I don't have the time to explore further. So anyone who wants to come back or get in touch with me, please. And then we have, how about collecting? It is not about collecting data. It is about collecting intelligent data that is able to be utilized. Yeah? And And also, the word surveillance here, perhaps it might look like, police are surveilling you, etc. No, it is about clinicians able to utilize technology in order to understand better the biophysiological mechanisms that are happening. This is very familiar. So this is precision psychiatry. I use this as a way of, make people understand that actually so many elements that needs to not only provide intelligent data, but also needs to be linked in. So if you take away the precision psychiatry to precision addiction medicine, I think you're all agree with me how important it is. But of course, that's anonymized and can be, collective integrated information is important. But then, of course, we need to use technology in order to support our patient population, as well as in order to understand the trends, the community, society. We don't live in an island. How is that affecting our universe that we work in? And yes, the answer is yes, we are technologically enabled and prepared to use artificial intelligence, some for epidemiological purposes, but others in order to create algorithms and decision-making tools. And there are some that's already being utilized, going back to the drug deaths, where there's one or two where they're even quantifying the level of risk of individuals of having a fatal overdose, for example. So yes, and I'm really encouraged that the strategy includes AI. We shouldn't be afraid of this, but that this needs some really careful work. But there is already data. There is already data that can be linked. There is already fresh, friendly, user-friendly, research-friendly data. And this is the type of data, linked data that we have in Scotland. So we have a community health index number. It's not my social security number or passport number, but it's been there for around 25 years. So all members of the citizens of Scotland have a CHI when they're born, typical, same as what's happening in Iceland. So there is data there that is ready to be interrogated, cleaned and research and clinically friendly data. And I've used that, in order to understand prescribing patterns, in order to understand compliance of medication. I mean, I think you were talking about a composite. So we looked at the use of a composite, for example, using linked data set, metadata, and you realize that 60% of all people prescribed a composite stopped taking their composite 2 months after being prescribed. So what are you doing? Even worse, if you followed those patients who had stopped due to non-compliance, half of them were dead within 2 years. So this is the type of data that needs to be supported and looked at from a patient population. Outcomes, the role of Suboxone, methadone study follow-up, which is, of course, other people are going to present on this. But data, intelligent data tends to be cheaper, quicker, faster to explore using proxy methodology, interventions as well, and also understand relative absolute risks and multiple morbidities, going back to this complexity, embracing complexity. This is one example of one of my PhD students who's exploring cardiovascular consequences in chronic opioid exposure and utilizing all these different data sets. Some are national linked data sets, others are specific for substance misuse. And there's a whole science around this in order to get the information that you're looking for, answer the question. So this is not about data mining, this is not about post hoc analysis, but a priori analysis based on the evidence that the literature is guiding you to utilize the. And the third one is technology. So, yeah, we're all carrying something in some form or another. Yes, so it's there. So what do you do with that? The problem, of course, is when it comes to getting the data, getting the technology, the medtech, medical technology, into NHS or other health and social care systems. It usually takes about 20 years, and perhaps, if you're lucky, 40 million pounds of investment. So how do you support this process? So I'm going to share with you where an initiative started 2 years ago in Scotland as a result of trying to reduce fatal overdose. We have agreed to support 6 to 8. Yeah, this bit of clinical research and a bit of regulatory. So I was honored to chair this Chief Scientist Office Innovation, Reducing Drug Deaths. It's an innovation consortium. And with the aim is, Scottish Government have identified, going back to that statistics in the first slide, that we have a problem here and we need to start thinking a bit outside the box. So, but we need to get academia, universities, industry, NHS together. And using this triple helix system, we were aware that this is not just about funding a research project and people becoming very successful. They publish them in high-impact publications, and that is it. You know, this is an intuitive process. We looked at what sort of tech there is that's already being used in the substance-using population. And there was a lot of them in different, using different ideas. What I find fascinating is the ring, you know, where you don't need to have technology that is intrusive or essentially, basically showing that you have a substance use problem and carrying is like, what police would do for criminals, putting the band, So we've put in this innovation priority challenge call specifically around reducing drug deaths, around innovative digital, alert responding pathways, enhance intelligent data, etc. And we had originally 12 projects which were supported through a £6 million grant from the Office of Life Science and the Chief Scientist Office around supporting prototyping. And we have 7 now who have passed the prototype stage and have moved on to demonstration stage. Most of them, surprise, surprise, is around overdose detection and response. How do you timely, effectively detect that someone is not in a deep sleep but overdosing? How do you integrate the technology? How do you make sure that the people, the families, the societies are empowered in order to understand what is happening? Because most people, the 1,500 of drug deaths actually die in people's sitting rooms, snoring deeply, with their families sitting beside them. But they don't realize that this is actually, they're dying, they're going through respiratory. So you have different, and again, this is about detection and response. So that's first category of demonstration projects that's going on right now. And then we have the overdose intervention. That's the second category is around, okay, I mentioned the Narcan, the naloxone, the opiate antagonist, but then at the same time, I just said that, most of the people die of a cocktail of sedatives, not just opioids. So how about if you look at the delivery system of Narcan, rather than having an intramuscular injection, you have a sublingual tablet, but also how about, or a patch, but how about having a controlled release combination of naloxone, which is the opioid antagonist, and flumazenil, which is the benzodiazepam antidote. So, yeah. So that's the story around, 3 elements. Food for thought, I'm sure you have lots of questions around that. As part of the International Society of Addiction Medicine, this year we have invited individuals, and we have organized a full-day pre-conference event around global addiction. And this is based around not just technology, but other ideas that are in the pipeline, or perhaps other people might have some ideas, but they don't know how to connect with other individuals. So you're most welcome. Participate. If you can't, next year it will be in Rotterdam. And looking, for, the work that you're doing in Qatar. So thank you very much. I have to acknowledge my team at St. Andrews, the Digitas St. Andrews team, Office of Life Science, Digital Lifeline, European Drug, European Union, and World Psychiatric Eyes. Thank you very much.
Thank you very much, Professor Baldacchino, for this really, indeed, innovative approach. We have time for some questions. I would have a question, if possible. It's particularly interesting, the use of smart devices that you mentioned. But practically, it would be linked like to community centers. How do you prevent overdoses through this? Practically, how does it work?
So the details, yes. So some companies are using clothes as sensors, physiologically identifying respiratory, cardiovascular, breathing, and other parameters, basic parameters. But the way they're using them, not just in rings and necklaces, but in clothes as well. But others are connecting with systems through GPS, with the ambulance service, with the treatment services, so that when there's an emergency, those systems work together. So there are different projects that are concentrating in different perspectives in order to get a timely response.
So practically, it would be very helpful since naloxone, most of the time people use alone, so they don't have, with this, it can really increase the chance of saving people, no?
Yes,
yes, absolutely. Okay, thank you.
Alex, what do you think about all these applications to manage our addictions, to offer us now nicotine, alcohol, to manage craving, to manage patients? What do you think about this?
Yeah, I'm never the type of person who would say no. Yes. But you need to manage data. You need to know why you're collecting certain data and how you're going to operate that data in order to make a difference to that patient's life, quality of life. I think that's the fundamental issues that, and again, I think the reality is that, yes, this is something that people with nicotine dependence. Some people, ask me the question and say, well, but there is online addiction, gaming problems, gambling problems, and you're introducing more technology. Well, actually, with a bit of face recognition and a bit of identifying the innuendos in social media and etc. I think it's important really to be intelligent about this. Thank you.
Alex, if I'm allowed to ask, you spoke about AI. You spoke about AI introductory there. Could you enlighten us of how did you start with that? I mean, what was the first things that you did with AI?
Okay.
In the context is, where did you start?
Yeah, actually, I got a piece of paper, hoping that someone would. There it is, with the list of things that I've done. So I'll share it with you. But what's important is that once upon a time, there used to be something called machine learning, supervised and unsupervised machine learning, which has been taken over by AI. AI means a lot. It's a group of activities. And we were fortunate enough to have data. So when I said about the PhD student looking at cardiovascular, we're able to interrogate data of 40,000 individuals and another 40,000 of controls. So, for AI to work, you need big data. And the unfortunate thing, and it might sound like voyeuristic, is that the fact that we have around 30,000 drug deaths data in the last 20 years is something that we're able to utilize. So the power needs to be there in order to interrogate the system. But also the ability to link the other data sets that are relevant to the patient that we're interrogating. was there as well. So that was the starting element. We've explored different types of AI, so to speak. And some were very disappointing, honestly. So we need to be very realistic about this. But what's important is that so that's why it was focused around reducing drug deaths, that there is a specific target focus for this.
Yeah. Sorry, Alex.
Oh.
Really impressive. I mean, the kind of collection the data collection. Have you got endpoints as yet? What's the difference? What difference has this made in terms of if you're talking about death by drug overdose?
Yeah.
Have you got some preliminary data showing that before
No, I don't,
after?
and I do not intend to. Because that's the type of very limited, sorry, I don't want to be insulting, by the way, but that's the type of very limited, what's the outcome? Has it made any difference? Because we live in a complex system, yeah? But we will measure once the products are in place within the system what has happened. But we cannot predict. That's the issue with prevention. If you save, or if 5 people have utilized the flumazenil and the antidote, then is that a success story or not compared to not utilizing it? Yeah, it is. It is hard. And outcomes are important. I'm not saying they're not important. But equally, we need to, as we're talking about social responsibility, I think we are in a situation where we perhaps start to explore these complex mechanisms and not go to funding agencies that specifically try to simplify what is essentially very complicated. There is funds there. Use the right narrative.
We have a question from Dr. Rehan, please.
Yes, thanks, Alex. Great presentation. So I would like you to elaborate on the ethical concerns for such intrusive devices, which basically means that patients will be monitored 24/7.
Yeah.
And why would anyone want to sign up for that?
Yeah. So hence the value of co-designing and co-production. So we have done a lot of focus groups, different patient population, even service users, service providers, nurses, doctors, who are asked to, in a way, expect that their patients would, use online platforms. But also, when this technology comes in, the fact that the Scottish government has been involved and the UK government has been involved, the ownership of what is essentially confidential data needs to be still owned by the person, him or herself. And there is a governance process is already being not just explored, but crystallized. How that is possible. Not easy.
We have no time for more questions.
Yes, thank you for
sorry.
last question. Don't you think that patients with this kind of devices, maybe their behavior to drug use will feel more secure or something like this?
Can you say that again?
I mean, the people with those devices, maybe his behavior to substance use will be, he will feel himself more secure.
Yeah, and interesting, Senator, because that again, we had all sorts of focus groups around not just acceptability, but usability of, one aspect, would these people sell the rings, etc., on eBay, for example? We joked about that, In Scotland, as a result of COVID, and post-COVID, we provide mobile phones to service users who've been discharged from prison, because we knew that was a risky moment in time to integrate with services. And we have tried, and part of the demonstration phase of those 7 companies is not only encouraging patients to be involved with the product, you know, the bulkiness and etc., but also around the ability to utilize this appropriately. This is a fundamental question, and thank you for highlighting it. But I remember 20 years ago around Narcan, the provision of naloxone in the system, and when Scotland removed the legal implication that it's not just clinicians or doctors who prescribe Narcan, but also handing over to families, etc., that there was a fear and anxiety that there would be an increase in black market or people utilizing Narcan as a punishment by criminals, you know, so putting people on withdrawals straight away. That really hasn't happened as such, but it's a managed risk. It is a managed risk because this is going back to the identifying, you know, the negative, positive risks. Is that question is saving a life, having, you know, 1 or 2 or 10, you know, utilizing that properly. But I think this is it. It challenges people's minds with a view of trying to find a solution.
Thank you very much, Professor Bazakino. Thank you.
Okay. Moving forward in this exciting symposium, it's my great honor to introduce our next speaker, Dr. Rama Kamal, board-certified senior consultant psychiatrist, director research and education and clinical lead for women in treatment service here in Naufar. Dr. Rama has 23 years of experience in the field of addiction in Netherlands and here in Qatar. She serves in the executive board of the World Psychiatric Association as a member of the International Society of Addiction Medicine. Dr. Rama is also a member of Education, Training and Exam Committee and has been examiner at Dutch Psychiatry Board. She has worked as senior consultant, addiction psychiatrist and clinical lead at GGZ, a regional mental health care institute at Nordic in Netherlands. Dr. Kamal is a lecturer in addiction medicine, specialist training at Radboud Nijmegen University in Netherlands. Dr. Rama regularly provides accredited training here in Qatar, Netherlands, and in Sudan in suicide prevention, alcohol detoxification, motivation enhancement therapy, substance use disorder treatment in primary care, triple diagnosis treatment, substance impact education, and so on. She has presented scientific papers in national and international congress and published numerous articles in peer-reviewed journals. Dr. Rama is a lead principal investigator and senior research. Her research interest is in the dual diagnosis, new psychoactive substances, genetics as innovative approach for precision medicine and personalized treatment in substance use disorder. Today, Dr. Rama will be speaking about the management of the opioid use through medication-assisted treatment with buprenorphine and how buprenorphine demonstrated intra-individual variability and how personalized dosing is important for the ensuing efficacy and minimizing side effects. Please join me welcoming Dr. Rama Kamal.
Good afternoon, everybody, and hopefully after the dip of eating and enjoying the discussion with Alex, and I am stepping up, so you can see me. So I hope today to be able to speak about medically assisted opioid use disorder and some aspect that we have been doing here, a study that we have been doing here in Naufar. I don't have any conflict of interest to disclose. But of course, I think I'm speaking to audience who are interested in addiction care. So we all know that opioid use disorder is effectively managed by medication-assisted treatment. Buprenorphine is actually the medication used here in Qatar.
where other countries are also introducing methadone and other measures to use there. We all know it's needed to reduce the mortality, morbidity, and of course have lower risks of overdose, as what spoke about. Buprenorphine, just a SNP, partial opioid agonist, which binds more to the mu opioid receptors, has high receptor affinity despite its partial agonist effect, and has a ceiling effect. That means that with certain doses you have the effect. If you increase that, it doesn't add anything to the clinical impact of the medication itself. It has some formulation, oral and injectable forms, and with long or extended release context like Buvidal, Sublocade, and there was also a formulation which is called Buprenorphine, which is actually what you call it, an implantate, which is now not used that much. All in all, there are so much limited data addressing, all the respective speakers before me emphasized of data coming from this region, from other entities than the Western component. So that part of data is still limited to look at what actually our population within this region will benefit from in those terms. So what we try to do with this study is look at the effective doses of buprenorphine for our patients and color that with the genetic analysis there. Again, looking at the perspective of adding the precision medicine flair there. What we did is actually collected data representing the period of treatment from July 20 until July 23, 2 years period, in which we were able to collect data of 566 patients included there. Some of them were treated by the oral format, sublingually, or they had longer-acting formats. And when we looked at their phenotype, which was addressed here several times, what is their profile? We looked at certain aspects like when did they come to us, their primary substance that they have been using, the age, education, employment, and other aspects there. But I wanted just to highlight what type of population do we have. We have a very young population. So I've looked at the percentage there. More than 60% of our patient cohort was actually younger than 30 years. And that's, in comparison with other countries, is really a young population concept. They were actually high educated. You expect, I'm not allowed to use the word junk here because Diana is going to kill me. But we have that stereotype of the opioid user who is actually miseducated and sitting under the bridge or wherever the context is. But they are really high educated patients. The level of education above high school and with college and university is respectively high. Most of them are single. I don't know if that's a context. Marry, that helps a lot to prevent problems. But most of them were single. If you look at their primary and secondary substance use, of course, all of them had opioid disorder, but they are also stimulant users. 30% of them were also using stimulants in addition to that, and cannabis. That's two of the substances which were actually well represented in this group. When we looked at their psychiatric comorbidity, actually 31% of the patients were diagnosed with a psychiatric comorbidity. And again, this is the information of the patients when they presented. So what was easily seen in the time of presentation, and I could assure you that that percentage went higher during the treatment and what we've seen there from their status. And of course, it is not different completely than the international data. The most presented psychiatric comorbidities, anxiety, and depression. And I'm still sketching this because we had during the lunch a very intriguing conversations about what we do. Do we really treat them take them as one package and provide integrated care? Yes, we try to, and it's actually basically a big challenge also to be able to do that. We looked at the cohort that we had and we divided them, and again, according to the substance that they were using. First cohort was the oral users of oral buprenorphine, Suboxone, sublingual films, or tablets users. And they were 413 in number. Then we looked at those who has been using Buvidal weekly or sublocade on a monthly basis, and that those were 153 of them. We looked at our measurements of is that MAT effective or not. We looked at the abstinence rate for these patients, that they were abstinent 12 or more weeks continuously, not using anything. And again, it might also bias our data in the context of give less effectiveness of the medication because we took complete abstinence, that they didn't use any other substance, not only the opioid, but also none of the other substances as measured. That is actually a very harsh measure to do. Then we looked at the genotyping. And again, I'm so lucky that all is said, but then I'll look at the clinical impact of that to look at the most relevant genes which could be implicated in the metabolism of this drug. When we looked at the oral medication form, in general, the average dose which was used in this group was averagely 15 milligram. And then we took the context of maintenance dose if the patient had this doses continuously more than 2 weeks. Looking at the description of the differentiation in the doses, I hope I can use the pointer. But you could see also that most of our patients had 60 milligram or more as their maintenance doses. So some of them who started in higher doses, but that these are patients who came back, which we knew that they are actually used to use buprenorphine, so it was easy to start them in a higher dose, and then they increase their maintenance dose into more than 20 milligrams. So you see that we're actually kind of in the normal range or higher range of the international perspective. Then we did the urine screen, as I said, to confirm abstinence. 34% of the patients were completely abstinent from any other drugs. Looks low, but for this type of population, to be abstinent from every substance that they are using is actually a big challenge, especially those who are using methamphetamine and cannabis therapy. Looking at that group who was actually abstinent from every substance, we've seen that the best abstinence was actually achieved with doses of 60 milligram and more. In the variation there. As you can see, 53% of the patients who were abstinent had a dose more than of 16 milligram or more. Looking at those who had an injectable form, and we're talking about 153 patients, just to state, all of these patients started with an oral prescription in which was transferred to an injectable long-acting. We used the concept of setting them in the right doses before switching into long-acting. Those who had Buvidal only were, in the majority, had a maintenance doses less than 32 milligram. Only a quarter of them were set on the 32 milligram doses. And 41% of these patients actually achieved complete abstinence. When we looked at sublocade, those who had sublocade only, started mainly with the 100 milligram, that mainly with less than half started with the 300 milligram, and they stayed on it. So actually, depending on the length of the oral application before that. And then we've seen that 51% of them achieved abstinence. In our perspective, and I think the clinicians here know that we had several patients who shifted between Buvidal and Sublocade for many reasons for that. But that 64 of these patients, and they had also, this group had 32 milligram in almost half of the population, but they showed periods of abstinence in 40% of them. Again, call it in that Buvidal period. When they went to the switch to this Sublocade, it seemed that they had more success with it. That's 70% of these patients in the Sublocade period were able to achieve abstinence. Then we looked at the genotyping of these patients, and thanks for all the speakers before me, because I'm not going to explain anything, so I'm just only going to flow in what does it mean. We looked at several genes, as I said before, but I'm going to speak about 3 of them. The CYP3A4, which was spoken about before as being involved in 90% of the metabolism of buprenorphine. That was really presented in 95% of the cohort, having the 1.1 variant, and that's actually what we call the normal wild type. These people who are able to have extensive metabolizing, and that means that they actually react normally on the medication provided there. So looking at that, we're saying, yeah, that is the expected metabolism of the drug, and without any further ado, they don't need any major adjustments in their doses. But that's one. When we look at the OPRMI, the A11HG, or HG, sorry, polymorphism, which is actually a very common polymorphism, we've seen that 73% of the cohort had also the AA variant, homozygous form, but that means a lot of things, because it's actually associated with different aspects. Those who have this allele have a problem of that they score actually more drowsiness, malaise, euphoria when they are exposed to opioids. But that means that, and they have also that their receptors respond more strongly to exogenous opioids. And we'll see the clinical relevant in that perspective. So they are more to be reflective when you provide an exogenous opioid. They have also a higher pain tolerance perspective, less increased nociceptive threshold. So that means that they are actually having a lower sensitivity to pain relief. So they feel it less, but if you want to relieve it, they have a problem with it. And then when we look at the digit simple substitution test, which was done for them, they showed cognitive slowing, and that means an impaired psychomotor function. That means that their central nervous system is affected more in the context of analgesia or, what do you call it, impact of the opioids itself in the sedative parts. So these aspects affect the 3 main things in our clinical practice, and it is actually the tolerance, the withdrawal, and also would impact our buprenorphine dosing. So if we're speaking about tolerance, these patients get quick tolerance. They will need more opioid for them to use more opioids to have the same stimuli that they're looking for. That means when they come to the withdrawal status, they will have severe withdrawal symptoms. which is actually means that we have to be careful when we are providing them with medication for that. In the context of buprenorphine itself, that means that we need to look at the doses that we're providing. When we are initiating the doses, these patients will have what we said before, drowsiness, malaise, impact of the medication itself. That means we cannot start high in initiation, so we have to start lower and build that up. And at the same time, we need to look at them, how are they going to react on the maintenance doses. The flip, that they need less maintenance doses, but higher doses if they are used in withdrawal status. So again, it's good for us to know that. It's saying that precision medicine, knowing that genotypes helps a lot. And then we looked at COMT. I think Prof. Amin has asked about how does it look like here? Can we use this variant? We've seen that 28% of our patients had also the AA variant of the COMT. What that means for them, that COMT is related to the, the metabolism of dopamine, norepinephrine, epinephrine. So that means if there is problems there, that this circle of metabolism of the major transmitters and enzymes in our brain will be different. If you have the AA variant, that means that you're actually accumulating this three neurotransmitters in your brain, dopamine, norepinephrine, and epinephrine. And that means simply that for us, if we're combining the psychiatric status, if this patient's having this, they are more prone for psychosis because their dopamine will be increased in their brain. They will be more prone to present physiological side effects, like what we're saying here, skin redness, things like that, which is related to their systemic context of norepinephrine and epinephrine level and balance. And in addition to that, there are patients who will have increased stress reactivity. That means that they will show more anxiety if they are in our withdrawal status or while we are looking at them in the context. That doesn't say that they have anxiety disorders, but they are more prone and more sensitive to that. So that may indicate for us that we need to play with the buprenorphine dose, to tune it to the need of these patients, to look at it and take in consideration their pain tolerance, their stress levels, how they are going to react while using, while having overstimulation or side effects. But imagine that a patient has both, has that OPRM1 and at the same time they have a COMT problem. So you have a double thingy. That means we have actually to do what we say opposite actions. When we are titrating the medication, we need to think about it. When we are adding, when we are increasing the doses, we have to think about it twice. And we might need to do opposite actions, but we need to be alert that this patient is reacting differently. So my take-home message, hopefully, that, yeah, buprenorphine definitely demonstrates different inter-individual variability and effect. And we need to look at what is the optimal doses that our patients will need according to their personalized aspects. Most of our patients achieved that the abstinence with a dose that vary usually equal or more than the 60 milligram. But again, we need to look at that in a specific perspective and an individual basis according to their genotyping color. That doesn't mean that we need to forget about the other aspects. It is important, but we don't know also the impact of neither epigenetics here. We didn't look at that. We don't know the impact of the phenotyping that they are having now. And for the psychiatric context, is there anything else? Is there this dose adjustment and I'm a clinician, I'm a physician, and by Brown we are biased to look at medication and the impact of and how does it look physiologically, but it's also important to take the other aspects with. And of course, and I think this is the message that we've been trying to say starting from Prof. Maadid until now, that it's not only that aspect, it's a very important aspect, but precision medicine doesn't mean only looking at the part that we're doing about genes, but it's also looking at all the phenotypes, epigenetics, everything that is related to that, and address, as much as we are doing the medication-assisted treatment, we need to do the part that packs the social aspects, the psychological aspects, and touches their behavior, therapeutic perspectives. I can't say anything except thank you for the whole team that have been working together, and it has been a hell of a journey to have all the possibilities and collect the data and look at what we're doing there. We're trying to play with it, Alex, as big data, but we are still there. So that's something that we hope that we could do in the coming period. So thank you, Munira, Mahmoud, Shidam, Hala for helping putting that, Qais, and of course Fidia for her guidance in that perspective. And I will never forget the words and the encouragement that I got also from Prof. So thank you all.
Thank you very much, Dr. Rama. Any questions? Dr. Rama, I just want to ask if, because our patients, they use multiple substances, while you said that they use other substances, including opiates. So have you seen that there is any dose variation in people like who use only opiates or who use other substances? Do you think that we need more doses of opiates in the people who are using on top other substances?
Well, thank you so much for this question, because that's the next question, research that we've been working on. So the data that Munira has presented, happy, dancing on the table, is one of the bronze that we are looking at in dividing the groups into opioid users only, those who has alcohol, those with polysubstance use, to see if we're seeing the same variations there if we're talking about genetics. But if we're talking, which will help us to look at the buprenorphine doses. Another aspect of it, if you're asking me, do we need to adjust the doses of the buprenorphine if they're using polysubstance? I think the international publication said yes, because you need to look if they're having sedatives beside it, if they're using the alcohol on a daily basis, what the impact on that, impact on the levels of the different neurotransmitters to back that up. I think we should look at it as any other combinations that we usually look at and be clinically critical while doing that. Thank you so much.
Thank you.
Thank you, Dr. Rama, for the notes that you did. I just have a quick question. It might be like a little bit of a zoom out from what you were saying, but it's considering that the anxiety and depression often pre-exist and contribute to the development of opioid use disorders, and knowing that psychiatric comorbidities also complicate the treatment, as you said, and the outcomes, do you think that earlier recognition and cultural acceptance of mental health issues in whether Qatar, Middle East, could significantly reduce the rates of opioid addiction? And furthermore, how can culturally sensitive precision medicine approaches integrate mental health intervention earlier in the treatment pathway to improve the outcomes of patients on medication-assisted treatments? Thank you.
I can read from your question that you're a psychiatrist from Hamad, but I'll tell you.
No, I'm actually a pharmacist, and I was working with the NHS, so that's my question, because I dealt with the different cultures, so I just wanted to see your perspective as well.
Thank you always for this question, and I think you touched two main things. I think that discussion has been there in the field of addiction psychiatry for ages. Is it the egg or the chicken? Do we start with the psychiatry perspective? Is there a reason there? And I don't know, I am from the group of integrated treatment, so you pick them both, you treat them both, you look with them, and you go parallel with that perspective. I might differ from other people here. I don't think if we treated the addiction in its own that we're going to tackle it. So we need to do it parallelly. But your second question was, if we do that timely, and you're speaking about prevention concepts, like looking at those who have anxiety and those who are vulnerable groups in perspective, can we decrease addiction? The answer, I think, globally will be in this context, yes, please do prevention. But again, that doesn't mean that it's in 100% line. So you try, yes, you try in schools, you try to defeat bullying, work on from young time, you speak about the stigma. And again, I'm not Qatari, I work in Qatar, but I'm also Sudanese, and I know what is the stigma is of addressing that you have a psychiatric problem. Let's say you say you're addicted. So both are needs from all of us in this field to work together and put hands in and then go through with it. So yes, of course, let us work together.
Any questions?
Yes, thank you very much. Thank you, Dr. Kamal, for your beautiful speech. You have showed us in the beginning of your speech and a trial, and you mixed biovidal and subalocade in long-acting versus in daily. You haven't a problem to explain the results after this, because you know, biovidal and subalocade is not the same profile. Okay.
Yeah. I'll just say the simple thingy, and I think Reham would suppose that we started with Buvidal, and we didn't have the long-acting at that time of Sublocade to be the people working with it. And what happened afterwards that we've seen that patients are more committed to the long-acting Sublocade, despite the different profile in that perspective, and that we had financially more success with it, but the other side also the patient had more commitment to that. So what we're doing now, we've shifted, I think, completely, and I'm looking at Reham because it's under his remit, completely to the long-acting Sublocade, as we don't give Buvidal unless the patient cannot tolerate long periods. So it's not given as a standard medication at this point. And again, that was until mid-23, so we had also to look at the consequences of that. So totally there's a different profile, I agree.
Okay, Dr. Rama, thank you very much.
Now I don't know what is coming, so I'm going to stop.
It's okay, it's okay. Thank you very much for a fantastic presentation. A question, how long do you think before the prescribing guidelines at Naufar will be able to take into account some of the genetic elements and the things that you're finding from the new research?
It's a very challenging question, and I'll say Jalal, step up. So no, it's the context of that we, at least what we're getting as preliminary data doesn't say that this is going to be the standard for now. We have to do a lot of steps in the research there to be in the step of translation, work with it, that it becomes a standard practice of testing the gene of the patient and then including that in the treatment prescription of it. But I think we're in the way. We started our steps there, and we're doing fantastic in that. In 2 years' time, we have achieved a lot, and I think all of us are proud of, and we made Prof a little bit proud of us.
I am very proud of everyone. No, seriously, what has been done is fantastic. It's just, you know, this Buprenorphine have a story. And I think I love to say it all the time, you know, because it gave me a headache at a certain time, okay? And it's relevant to the precision medicine strategy that we have today. I've been signing the checks. And I can see that I'm signing more and more on the medication. I look at the statistics, the number of patients the same, and so I'm asking, and then we have another pressure because there is, even the psychiatrists here were split, and pressure from other institutions, psychiatrists everywhere else to say, guys, you are putting too much, you are doing this and that, and I was at a dilemma. Who should I believe? Who should I then? Because there is evidence for in all directions. So I remember I called Professor Vidya. She is my deputy, or, you know, at the Center of Metabolism in London. And I said, Vidya, can you help me here? What can we do? I need a solid answer on this. And that's how our precision medicine, we looked at it, and then we said, okay, let's do a complete review on our system, on our this. And that's where we say, okay, we need to adopt more quantitative kind of strategy. And I just wanted to share that sometimes if you really look, don't solve a problem. You go to the root cause analysis of that problem. Regarding the last question Annette asked, guys, life is, or when you run an organization, it's like what you have your quality system. Okay? You build a system and you do review all the time. You see what's missing, what innovation is coming in. Do I adapt? You measure. You see your impact. Is it achieving? If it's not, you review. You build again and again, and you build. This is why people who stagnate actually don't go anywhere. You have to be on your toes all the time. If you really want to be successful and you impact your patients. Okay, sorry, I just wanted to share.
No,
that.
just
I love sharing stories at this age. Anybody want to hear more stories, please contact me.
I think a small addition to what you said here is that we are really doing that and stepping up in that genotype perspective. But we really need also to do what we call a proof of concept. So we need to go back and check if that also works for these patients from pharmacokinetics thing. And then we can say this is it and then produce it. But thank you all for listening to me and bearing me.
Thank you very much, Dr. Rama. So we'll have a coffee break now. I've been told that it would be 20 minutes and not 30, so we catch up on time. So if we can be back at 3:30, thank you. So we're gonna start our last part of this interesting day. I'm very happy to introduce Dr. Nathalie Rieser. Dr. Rieser got her Master Science of Cognitive Psychology and Cognitive Neuroscience from the University of Zurich. She then expanded her research in her postdoctoral to study how induced altered state of consciousness affect the brain. Dr. Rieser is currently now in Johns Hopkins University, and she's working mainly on psychedelic research, which is really the hot topic for the last years and a major breakthrough in psychiatry. So her talk now, she will share with us today a study on the use of psilocybin in alcohol use disorder and mainly in alcohol prevention. Thank you. Alcohol relapse prevention.
Thank you very much for the invitation. I'm excited to talk more about our recently published study where we investigated psilocybin-assisted therapy in the treatment of relapse prevention in alcohol use disorder. For some people here, it might seem very surprising or even shocking that we would think about using a psychedelic, which is also used recreationally, to treat patients with a substance use disorder. However, I hope after this talk, it becomes clear that we always talk about a 1 or a 2-time dose, and that this dose clinically, in a clinical setting, is very safe, and that we show, or that there is very promising efficacy with these substances. I have no conflict of interests to disclose. As we all know, I think here alcohol use disorder is characterized by recurring cycles of treatment, periods of abstinence, but unfortunately also relapse. Within 6 months following a withdrawal treatment, patients with alcohol, 60% of patients withdraw, and this is why we wanted to see, they relapse within 6 months after a withdrawal treatment. And this is why we wanted to see whether we could support these patients in this difficult and very vulnerable time period after a withdrawal treatment to increase abstinence rate and abstinence length. Quickly talking about psychedelics, why we would even want to study these, where this idea comes from. Psychedelics are a wide variety of substances, mostly at the moment focused on the research mainly focuses on psilocybin, which is the active compound of magic mushrooms. There's also studies about LSD and more coming up with DMT, ayahuasca, and 5-MeO-DMT. In the 1950s and 60s, numerous studies showed very promising efficacy in the treatment of various psychiatric disorders. However, this research was stopped and taken up again. A meta-analysis recently published summarized the AUD, the alcohol use disorder trials of the 50s and 60s, and they showed very promising efficacy. However, the studies that were conducted in this time period don't fulfill current criteria of our clinical trials, which is why it's very important to investigate this in more depth with the current standards. Substance use disorder is not the only psychiatric disorder that had some clinical trials with psilocybin. Most of the trials were actually with major depressive disorder or treatment-resistant depressive disorder. We can see here, pointer, okay. On the left corner up, you see the biggest study with a multi-center study which showed very promising effects of a single dose of psilocybin. Then below, another study showed that psilocybin-assisted therapy in major depression was just as good as escitalopram, which is a very, very often used antidepressant. Another study in another group showed that these effects of the single dose or 2-time dose lasted for up to 12 months after the substance visit. And I think this is very important to say. We use a 1 or 2-time dose, and the effects seem to be very on a long-term basis. There's also another very small pilot study published about tobacco addiction, and a lot of studies undergoing investigating different substance use disorder, other psychiatric disorder, but also other disorders such as Lyme disease and Alzheimer. While we were doing our study in Zurich, there was another group published a bigger trial, a randomized clinical trial with 93 patients with alcohol abuse. They used 2 doses of psilocybin between 25 and 40 milligrams, which is considered moderate to very high dose. The current belief is at the moment that patients with substance use disorder might need a bit of a higher dose compared to other psychiatric disorders. Here you can see here that after the second dose was administered, the psilocybin group drank significantly less, so they showed less heavy drinking days following the second dose in comparison to the placebo group. The same was for number of drinks per day, where you can also see a significant decrease in the psilocybin group compared to the placebo group. So this was very promising, and we wanted to see specifically whether we could transfer these promising effects to a relapse prevention framework. Furthermore, given that this treatment is very time-intensive, where a psychiatrist or also a nurse has to be with the patient for at least 1 day during this substance visit, because this subjective effects goes up for a day, so there always has to be a person or 2 people with the patient. There's also preparation and integration sessions, but I will talk about this in a second. So we wanted to see whether we could increase the accessibility by using only a single dose of psilocybin, which had shown previous efficacy in the treatment of major depressive disorder. Furthermore, very interestingly, we have these studies showing promising efficacy. However, we're not sure where these effects are coming from. So what are the underlying mechanisms of action? And this is something we were also very interested in Zurich, and I will also talk about this a bit more. Just as a recap, we wanted to see whether we could increase abstinence phase after withdrawal treatment, so all the patients underwent a withdrawal treatment before participating in our study. This was not part of our study design. They had to do this individual, and it was either inpatient or outpatient, whatever worked best for the patient. We included 37 participants or patients with alcohol use disorder. We aimed for 60, however, a pandemic came in the way, and half the participants received psilocybin, 25 milligrams, or a placebo, which was a very inactive placebo, so there were no subjective effects. All the participants filled in the timeline follow-back, so we could assess how much alcohol they drank per day, and this was done over the whole time course of the study until a 6 months follow-up. To talk more a bit about the setting, or also especially the therapeutic setting, after a screening visit where we went through all the inclusion and exclusion criteria, which are currently extensive to ensure the safety of patients. All the patients underwent a preparation sessions where we talked with them what they can expect from the day, from the substance, what they want to work on, and what their goals are for the future. We used a semi-standardized interview called Brenda, which has been used in other RCTs in substance use disorder, and it's based on the principle of motivational interviewing. On the dosing visit, there was no therapeutic session or no active intervention. If the patients wanted to talk to us, we were, of course, there for them all the time. However, we encouraged them to look inwards and focus on themselves and focus on their goals that they set in the preparation session. Following the dosing visit, there were 3 follow-up sessions, all of them also containing therapeutic elements. On the first post-treatment was 1 day, the second was 2 weeks, and the last one was 4-week follow-up, where we talked about what came up on the session day, How can they transfer this to daily life, and what would they like to change, and how do they want to change things? Then the 3 and the 6 months follow-up were done online, so they just filled in a survey. All the therapy sessions were recorded so we could analyze qualitative data, except the dosing visit. To assess more of the mechanisms of action, and there's this hypothesis that psychedelics induce or improve empathy, which is why we wanted to assess this, whether we can see this in our patient population, which is why we did pre and post multifaceted empathy task, which is measuring both the cognitive but also the emotional empathy. The patients also underwent MRIs, one at baseline, one acutely, and one at the 4-week follow-up. And this is to assess the mechanisms of action. They always underwent a resting state and a cure activity task. The cure activity task is here to induce craving, and the autobiographical task and the DTI was conducted only pre and post, or at the 4-week follow-up. So what we were interested in is the abstinence rate at 4-week follow-up, the mean daily alcohol use up until the 4-week follow-up, and craving and self-efficacy at the 4-week follow-up. Here, a quick overview of our sample. We included 37 participants, 18 received psilocybin, 19 placebo, and they were matched very well regarding sex, age, and verbal IQ. The alcohol use characteristics were around that they drank 7 drinks per day before undergoing the withdrawal treatment. However, you can see there's quite some standard deviation. So the sample was very heterogeneous. Also, the days since our last alcohol use was very different between patients, but not different between the groups. With that, I would like to present our results. We were very surprised to see that we found no effect between the 2 groups. So we found no effect of psilocybin in abstinence. Here you can see the survival analysis for the 4-week follow-up, and I promise you the 6 months follow-ups looks basically the same. I hope it's big enough to see. Both groups showed in the end 7 patients who did not relapse, and all the others relapsed within the first 4 weeks. A relapse was defined as more than 1 standard unit of alcohol. Of course, there are a lot of different definitions of relapse, but that's the one we use. We also found no significant difference in mean alcohol use between the 2 groups. On the right side, you can see on the x-axis the days post-substance visit. So after they took the substance, how much did they drink between the 2 groups? The green one is the psilocybin group, and the purple one, the placebo group. And while the psilocybin group might have started off a bit better or a bit lower, there was no significant difference between the 2 groups. Both groups reported approximately 1 alcohol unit per day. And this is the graph for the 6 months follow-up, which looks also very similar between the 2 groups. We can see very nicely, or not nicely, but how both groups increased their alcohol use after the withdrawal treatment in a very similar pattern. We wanted to see whether we could replicate the results found by, reported by this other group that reported percentage of heavy drinking days. And also here we found no difference between the 2 groups, showing a very similar pattern than the one you have seen before. So this was very surprising, but it was not the only thing we looked at. We also looked whether craving changed between the 2 groups, and what we found is that craving was significantly decreased in both groups, 1 day follow-up, but not later on in the psilocybin group. So both groups had a significant decrease, with the psilocybin group an additional decrease. However, this went back to the same amount 2 weeks later. We found also increased efficacy after psilocybin and placebo administration. Again, here on the left side, you see the temptation to drink alcohol, which decreased in both groups, with an additional decrease in the psilocybin group. We found no difference in the confidence to abstain from drinking alcohol. To sum these results up, I guess you could also follow, but we found no effect on abstinence rate, mean alcohol use. We found a decrease in craving, however, that was very short-lived. And we found an increase in self-efficacy to abstain from drinking alcohol in both groups. We, as you all know, very often patients with substance use disorder also show other comorbidities, or alcohol use is not the only thing that they want to work on or what they want to change. So we also looked at secondary clinical measures, and in line with previous research, we found that psilocybin significantly decreased the depression scores, which was not seen in the placebo group. And the psilocybin group actually went below the remission threshold of the BDI, Back to Depression Inventory, a very common instrument to measure depression scores. We also found decreased hopelessness after psilocybin administration, but not placebo administration. Decreased suppressive emotion regulation strategy after psilocybin administration, but not placebo administration. However, we found no difference between on the adaptive emotion regulation strategy, cognitive appraisal. We also found a decreased negative effect after psilocybin administration, but we found no effect on positive effect, and we found increased quality of life after psilocybin administration, but not placebo. So these are also very important measures and might reflect that the patients actually felt better. However, this was not translated to their alcohol use characteristics. Starting these new studies, it's also very important to talk about their safety profile. And this is why I'm showing the adverse events that we had in our trial. The ones prior to substance visit were maybe not so important here specifically, but acutely, 2 patients in the psilocybin group reported nausea, which is a very common side effect in these substances. And the next day, 5 participants reported headache, which is also very common side effects. However, there were no other notable or interesting adverse events. We had 5 serious adverse events. Serious adverse event means that they had to undergo a clinic or had to stay at a clinic. All of them were inpatient withdrawal treatment, which I think is also very expectable in this sample. 4 of them happened in a placebo group and 1 in the psilocybin group. So all in all, the 25 milligrams of psilocybin administered in our trial seemed to be a very tolerated and safe dosage in a clinical setting. So prior results in humans may not translate to the present relapse prevention framework. We think we had a more severely affected sample in our study. And interestingly, a preclinical analysis showed that alcohol relapse severity was negatively correlated with neural responsivity to psilocybin treatment, meaning that the treatment may be less effective in more severely affected alcohol use disorder patients. However, this is something that needs to be studied further. We also had differences in the study design. For example, maybe you already noticed we used a single dose. The other trial used a 2-time dose, and we had 5.5 hours of therapy that was implemented in the study protocol. However, the other group had 12 hours of therapy. So it's basically double the intervention. Interestingly, the results are in line with animal research done in this relapse prevention framework with both psilocybin and LSD. So psilocybin-assisted therapy may be effective in reducing alcohol use in active users. However, it may not prevent relapse after a withdrawal treatment. Importantly, however, I think the improvements play a very important role in the patient's life, and an increase or a decrease in depression, hopelessness, and increase in quality of life, and improved emotion regulation strategies are important points to consider. We have more data to be analyzed. As I mentioned before, we want to look at the mechanisms of action. One of them is whether we find altered brain connectivity pre-post, but also acutely. We also want to see whether patients report different or altered reward and emotion processing. We use tasks in the MRI, but also questionnaires and the therapy recording for that. And we also want to see whether there's altered social connectedness, if patients feel more connected to their environment or to their peers, which we also have a task for, and the qualitative analysis. And the last slide, I quickly want to talk about precision psychiatry, given the topic of this symposia. We want to see whether we can, or whether baseline MRI can predict the treatment outcome. We have seen in healthy controls that baseline MRI was predictive of the neural response acutely. However, there is no study currently that has been done in patients. And we also want to see whether we can look, or whether personality characteristics are predictive of treatment outcome. And given the high variability of patients, it's not just how severely affected they are, how much they drink, do they have comorbidities, do they use other substances? It's also how far are they with their therapy? Is this their first therapy? Do they have a long time period of therapy? Is it better to have this as a first therapy, or is a long therapy needed for that? There's still so many questions that need to be answered with this research. And I think it is very promising, but more research will show how promising it is. And yeah, I'm very curious to see what the future holds for this research. With that, I would like to thank my supervisors, colleagues, but also students in Zurich who supported this study intensively. And thank you all for your attention. And I'm very happy to take any questions.
Thank you very much, Dr. Rieser. Very interesting findings. What's interesting is it's effective in mood symptoms and not in alcohol use symptoms. Do you think that if maybe for substance use or alcohol use specifically, we would need a different protocol in terms of higher dosages or more frequent dosing or than the ones used for mood disorder?
So that's a very good question, and I think we should just do the research. I can hypothesize about it, but I think the research behind it will show what exactly we need to adjust. I could imagine that a 2-time dose would be needed, just to acclimate the patients to the substance, and then have another substance to really work on themselves. I think this could be helpful. And but higher doses, so when we started the study, 25 milligrams was considered a high dose, and now it's the normal dose. So this is also a very interesting change in the last 7 years, which took us to do this study. And they went up to 40 dose with alcohol use disorder patients, which seemed to be safe as well. But I think there should be done more research before we try it out with patients with different dosages and things. Yeah.
Thank you very much. It's fantastic, and I'm very interested because we have published this month in Journal of Psychoaffective Disorder. Romeo and All from Paris-Saclay, it's my team. And the title, Exploring the Factors Affecting Psychological Flexibility After Psychedelic Experiences. We're going to begin our protocol, and I confirm this parameter, psychological parameter, is very strong parameter, and I want to confirm your
your expenses, we are going to make 3 doses of psilocybin and alcohol. Mm-hmm. It's not relapse in the manage the craving. Okay. What do you think about this parameter? Have you explored the flexibility, the psychological flexibility?
So we actually didn't assess it in this trial, but there has been shown that cognitive flexibility is important in major depressive disorder and also predict a treatment outcome. And at Johns Hopkins, we're actually running a study looking specifically or more on the mechanistic sides of the psychedelics, and we also assess cognitive flexibility in healthy controls. So I think very good call for this protocol, and I think it could be very interesting. Yeah.
Thank you very much.
Sorry, thank you very much for your presentation. I just wanted to try to better apprise and understand the whole results, even there are partial results for now. It's what did you tell to the patients before starting the treatment? Because you see, one day after starting the treatment, there is an acute response of both the experimental and the placebo group. So what did you say to the patients? So we see this one day after and then progressively coming back to the normal. Thank you very much.
Yeah, we were also surprised to see this, and a lot of patients in the placebo group, we were double-blinded. Sorry, I think I didn't mention that. So we actually didn't know who received psilocybin and who received placebo. But with psychedelics, it's very, people notice usually whether they received the psilocybin or the placebo. If they have subjective effects, they got the psychedelic, and if not, they didn't. And while some patients were very disappointed to get the placebo, I think they often reported that they really enjoyed the day with us, that they enjoyed this whole day, that they didn't have to do anything and could just relax and focus on themselves, and that this helped a lot to decrease the craving. So I think maybe it's just stress reduction, self-awareness, more time for themselves, and they spend the whole day with amazing psychiatrists. Yeah, I don't know. Well, not me. I wasn't a psychiatrist in this, but my colleagues. Yeah.
Thank you very much. Thank you very much. Very nice presentation. Very interesting findings. I had a question because it seems quite stark that it has no effect on relapse rates for alcohol, but it has such sort of seemingly significant effects on depression. Was co-occurring alcohol use disorder and depression looked at? Was this as a sort of as depression contributing to relapse to alcohol use disorder?
So we looked at comorbidities, we assessed those, and I think some patients had also a concurrent depressive disorder. However, some of them had ADHD disorders, one had a personality disorder. So given the small sample size, we couldn't do another subgroup analysis, unfortunately. It's just, we would have loved to have a bigger sample, and interestingly, at Johns Hopkins, they're now, and I think they're now presenting the first results of concurrent MDD, major depressive disorder, and alcohol use disorder, and they show, again, very promising results, so, yeah.
Okay, thank you very much, Dr. Reeder.
Thank you.
Thank you.
Thank you very much once again, and it's my great honor to introduce our next speaker, Professor Vidya Mohammad Ali, the Deputy Head of the Department of Inflammation and Rare Diseases and Deputy Director, Center for the Metabolism and Inflammation Division of Medicine, London, United Kingdom. Professor Vidya worked here in Qatar from 2012 till 2017 as Director of Life Science Research in Anti-Doping Laboratory, and from 2018, she is a scientific advisor. Since 2015, she has been a member of the Medical and Scientific Commission International Olympic Committee. She formed an adipokines and metabolism research group at University College London between 2001 and 2013, investigating the endocrine function of the adipocyte and its consequences in a non-communicable disease. Professor Vidya has contributed over 300 conferences, proceedings, and media output for the wider public, and attracted funding for several student stipends and grant funding of £2 million, published over 100 peer-reviewed papers on anti-doping research and non-communicable diseases, and she also contributed chapters for 3 books. Her work has been cited over 8,000 times, mashallah, with an H index of 55. Well, gut hormones like ghrelin, GLP-1 and peptide YY are responsible for regulating our appetite and food intake. Well, they also influence our brain reward system and may play a role in substance seeking and relapse. Professor Vidya will speak about targeting this gut-brain axis for substance use disorders. Please join me to welcome Professor Vidya Muhammad Ali.
Thank you. I mean, all that huge introduction means that I'm old, so I've had a long time to achieve quite a lot of this. Anyway, that's the only difference between me and you, Natalie, nothing else. Okay, so I have to say I feel a little bit of an imposter talking about the gut-brain axis, but when Rama and myself, when we were talking about, and Prof. M, when we were talking about this program, we felt it has to be as comprehensive as possible. While, you know, what you just talked about was the latest sexy thing that we should be looking at, but also with the huge increase in the use of Ozempic and Wegovy and Mounjaro, we felt we can't leave that out, and we really need to include that in this program. Prof. M's question was immediately, what the hell do you know about this? You know, and I had to immediately fish out a paper that this is the thing about being old enough. You've been there almost with everything that he asks me. I said, oh, I think I've got a paper somewhere that I've published. So you can see, you know, 10 years ago, I had because I come from non-communicable diseases, obesity is an area that I was working in for quite a long time until I kind of came here a little bit kicking and screaming to become an anti-doping person, which I'm learning about. I'm Indian by origin. We don't do exercise. About the only time I run is if I'm running to the lift, okay? So that being the case, I always feel, what am I doing in IOC, in the International Olympic Committee? You know, that kind of stuff. But this is where it all started, with discussions, you know, about the huge numbers of people here who are taking this, you know, and even though the initial criteria was about BMI of 27, then it came down to, went up a little bit more because the use was getting quite worrying, and unsupervised use was getting quite worrying. And I told Rama about this work that was done by Noura Rashid. You know, when I came, she was one of my PhD students, and at that time we were looking at obesity surgery. We were looking at Roux-en-Y bypass surgery and individuals. There are about 20% of these individuals who carry on having nausea, vomiting, even though they have lost weight after bariatric surgery. They have horrendous chronic nausea, vomiting for over a year, 15 months, 18 months, some of these. So it's quite debilitating for them. And then we wanted to look at what exactly is happening to them. And, you know, this is what we found. So you can see there, they lost weight just like the people who don't have the nausea, vomiting. But I won't show you all the other data on that. But the major finding of that paper was, look at the GLP-1, well beyond anything else that we saw with any others. And these patients, we wanted to look at their GLP-1 in the fasting state as well as after food load. And we wanted to do an oral glucose tolerance test. Actually, many of them couldn't tolerate eating that much, you know, and they felt, oh, I can't eat that much in one setting. And their whole relationship with food has changed, and almost any of the things we were talking about. So 10 years on now, that's exactly what we're seeing. Lots of people are on this. It has huge, I am a fan if it takes you away from surgery, if it actually gets rid of your diabetes, for sure. But we need to kind of be aware of this. And then, so that's where, the story began. But I have colleagues who were working with us. They were working at the Hammersmith, at the Imperial College. They were real gut hormone people. I'm a fat person. I'm an obesity adipose tissue person. I'm looking at adipose tissue as an endocrine organ. So leptin is my thing, or IL-6 is my thing, whereas these people were all looking at the gut. So what is it? The GI tract is the largest endocrine organ in the body. These are all, to me, they really, especially when I talk to students, this is all very, very nice. Back in 1990, December 1990 was the advent of leptin. Now we're talking about, I can't remember exactly ghrelin, but it was around 1996, I think. So these are all endocrine systems coming into within the time when we can remember. It's not something that had happened like insulin or any of those kind of things. So it gives us a chance to start thinking about new studies and what they do. And we're still at the very tip of it. So largest endocrine organ, there are about 20 or so, including things like PYY that you mentioned, that are coming out of the gut. And they influence a whole load of physiological processes, act on lots of tissues. Smooth muscle, of course, is a major target, but also the peripheral nervous system is one of its targets. It's very sensitive to the gut nutrient content. We don't know about the nutrient composition, but there is certainly a huge thing. And it changes both hunger and satiety, depending on which gut hormone, and I will show you that. If you're talking about ghrelin, that's a feeding signal. So you have more ghrelin, you want to go and eat as much as you can. And I just spoke to a colleague here. The microbiota is enormously important when we are talking about the gut-brain, but I'm not going to talk about this at all today because it just muddies the water, and I can't think about too many things at once. I'm a very, very simple scientist. It has to be quite, okay? So coordinated changes in the circulating. So where does it all come from? So the hormones, you can see that, I don't know how to use this, Fatma. Is it this one? I don't want to do what Prof. M does and switch everything off. So, okay. I think it's supposed to be there, but it doesn't matter. So you can see that ghrelin gastrin comes from the stomach, and at the same time, in close proximity, of course, you have the pancreas, where you have insulin, glucagon, PP, which is pancreatic polypeptide, amylin, things like that, CCK, GIP, all of those come from the small intestine. Oh, sorry, sweetheart. Can you see something? Oh, okay. It's okay. It's there. Do you see my dot? Anyway, then you have GLP-1, GLP-2, oxyntomodulin, PYY. I remember actually having somebody calling me up, and I had to go and give a little I think it was in BBC or something like that, about oxyntomodulin. And again, when that came up, it's a bit like the GLP story at this time. Okay? And these hormones signal from the periphery, from your gut to your brain, to regulate various processes. The process, of course, we were mainly interested in is to regulate energy homeostasis. We were talking about obesity, so that's a big thing that we were looking at. As we said, they come from the L cells, usually postprandially, so it's immediately after a meal, and they stimulate the anorectic pathways in the hypothalamus and in the brainstem. There's still a lot of debate as to whether they actually cross the blood-brain barrier. Many of them don't. They actually signal at the brainstem, seems to be, and all these green lines are actually showing you that they are actually orexigenic. They're feeding signals. And if they're the red lines, then they're actually satiety signals. And these are the ones, I'm not going to go into great detail about the neurons. The NPY neurons, the POMC neurons are the major ones that are involved in this. and within the arcuate nucleus is the region for it. We've been talking about these gut peptides for, as I said, at least about, I think Steve Bloom probably for about 30 years. And I always mention Steve Bloom. In London, there's always a competition as to who's publishing what. We leave him out of it because he's actually published over 3,000 papers. What the hell is that? I mean, nobody does that except him. But then he has no other life. So he publishes. That's our thing, okay? So everything, his whole life has been about these gut peptides. And I'm really sorry to say he didn't actually come up with this medication. He must be completely, gutted that he's not doing. So GLP-1 receptor agonist, you can see that it got FDA approval for type 2 diabetes back in 2017, 18, FDA in 2017, and the EMA, the European Medical Agency, in 2018, and then moved into weight regulation in 2021. The doses are quite different. Much lower doses for type 2 diabetes, much higher doses when you come into obesity. I mean, the minimal maintenance dose you're talking about is about 2.5 mg, sometimes up to 5.05 mg itself. Okay? So you do get, one of the big things about this is that nausea, vomiting is something that quite a lot of them complain about. They also complain about depression as being. Our relationship with food is a very, very important part of our lives. So when you take that away and you don't have any pleasure from it at all, it sounds fantastic to me. You lose weight, but it's not such a, almost all of our social. So if you're thinking about holistic well-being, then perhaps that becomes. So now there's interest. You've kind of gone through diabetes, you've gone through obesity. Now the interest has been in Alzheimer's disease. And you're talking about SUDS, of course, for us here, and as well as other mental health conditions. So it's a bit like your psilocybin, You did think that it was all just for fun and you have your magic mushrooms, but that's not the case. You have now an excuse as to why you have to take your magic mushroom. Okay? Many of the same behaviors, you have to remember that what happens in obesity is pretty much what you're seeing in SUDS. And if you look, I think in the first symposium here, there was somebody who presented a whole load of fMRI data, and you're looking at the centers within the brain that affects appetite. And it's almost exactly the ones that you're seeing here for your cocaine addiction and any other forms of it, So there was a suggestion quite early on that there are shared neural substrates, perhaps, and certainly pathways between addiction and food consumption. And I'm sure, Rama, you would probably say that food eating disorders are pretty much, part of your repertoire. It's not, it's yet another drug. So food intake, appetite, regulated by many of these hormones with a big crosstalk between, and it also includes things like reward sensitivity. It includes things like stress, impulsivity, compulsivity, all of which comes into SUDS rather than just, and certainly when I used to run obesity clinics, that was one of the things that you're told about eating behavior as well. It's a compulsion. It's not something that they need to live or anything, they just can't stop. And it's exactly the kind of thing that you see here. Okay? And the gut hormones, as I said, have receptors across many, I'm again going to run through this, and they're thought to be, it's really dysregulation of these different neural circuits that are involved in the various stages of the addiction cycle. So it's not just, when you're talking about the initial as well as subsequent to this. The reason why I'm being quite airy-fairy about this is because the evidence for any of it at the moment is still, somebody from the audience, perhaps Jamal, differently, but in the pathways when I was looking into it in the last few days, it just doesn't seem to be there other than it works in some studies, okay? So seminal research back in I think it was about 2012 was the first paper that really suggested that hunger signals are regulated by these gut hormones in the endocrine pathway, and they also promote the whole drug use thing. They put the two together. And these 4 papers were actually the seminal papers in this area that suggest that eating behavior and SUDS may be seen as one and the same as within the spectrum of SUDS in one way. Okay? And then, of course, the whole thing was to, which made me very happy, is to not leave out the adipose tissue. Leptin is actually the hormone from the adipose tissue, and there may be crosstalk between them, and that's something that really needs to be looked at. So this whole thing about common treatments for the regulation of appetite and SUDS is now doing the rounds. That's why we're talking about it here. So there are shared hormonal pathways that regulate the processes of energy homeostasis, as well as the psychiatric states that are involved in addictive behavior, addictive disorders. And it raises these kind of possibility that they are the same targets. We should be thinking about similar targets for treatment intervention. And this has actually led to considering addiction as a disorder that also involves these gut peptides, these gut hormones. And new medication, all these medication that's coming out, should be tried. As I told you, one side of the question is actually GLP-1. And GLP-1 is actually stopping you eating. It tells you, I'm full. It's a satiety signal, also coming from the gut. Then there's the other side of it, and that's ghrelin. And that's actually saying, eat as much as you want, eat more, that kind of. Both of them have actually been thought of as good targets. An antagonist of ghrelin has been used and certainly shown to reduce not just food intake, but alcohol intake. Voluntary alcohol intake was found to be significantly reduced in those people who are having ghrelin receptor antagonists. Not those people, those rodents, because they did it in both mice and rats. And they showed that amphetamine, cocaine, as well as alcohol intake was reduced by this. Human studies on those have been very, very poor. And the numbers are not big enough for actually anybody to reproduce, and it hasn't been. And so that's the space that we're watching now. It does show that ghrelin administration increases your neural signals to food and reward and incentive, etc. But when it actually comes to alcohol or cocaine, or the results have not been very reproducible. And I've only seen it, good papers of that has only been in, And as the other paper that I've seen is that ghrelin levels significantly elevated, both fasted as well as post-absorptive, non-fasted as well as fasted, in alcohol use patients, as well as in cigarette smokers. And it's associated with relapse, time to relapse, smoking relapse. This is something we should look at. We should look at ghrelin. We should look at GLP-1 in our patients and see what they're doing over there. And it might give us the kind of evidence to kind of say, okay, this is really a thing that we can go ahead. And I haven't seen enough numbers of those. And especially when we're talking in a place like Qatar, where obesity is very, very high. Levels of obesity is huge. Levels of diabetes is huge. So we should be thinking about what's happening to the gut peptides, in these individuals. Is there a susceptibility conferred because of the gut peptides? It's very interesting. I don't know if you were quick enough to see the data that Munira flashed at you. There was a GLP-1 receptor gene we are looking at. And it seems to be the 3 variants that we're seeing, they all have one predominant one, but we haven't had the time to go back and look at what it means. As I said, we've only had that data for about 48 hours, and much of that 48 hours was preparing for this conference. Okay? So future clinical trials really need to think about, so there was one other issue that they also, these are now GLP studies, that was ghrelin. And then these GLP studies have also shown that there may be good response to alcohol. Alcohol and smoking are the 2 that seems to respond quite well to Ozempic, to Wegovy, to the ones that we're talking about in GLP. Not only GLP-1 agonists, but also GLP-1 receptor agonists. So that's important to remember. There's definitely, you pointed out, I think about gender differences, sex differences in all these need to be looked at in whatever situation that we're doing. And they showed that GLP certainly seems to be much more marked in women than in men. And there may also be, differences. But the problem is the addictive behavior itself is different even before you put in the therapy between men and women. So it's a little bit difficult to tell, but we need trials. These are the papers that I saw. And I was asking Natalie, had you seen anything more recently? These are the only ones I saw. There was a big meta-analysis. This is the paper that where they looked at the association between GLP-1 receptor agonist use and alcohol consumption. They had done a huge review on that, and you can see the number of participants are big. But the RCT data there didn't show any real reduction in alcohol consumption over the 30-day period that they had set out in most of these. In the GLP-1 agonist versus the placebo. There was definitely a group that responded really well, and it's very interesting, that group that responded really well were the obese individuals, were the ones with BMI, and you do have people who are under that criteria within your clinics. So perhaps that is something that we need to see why it is, and then we can look at exactly. And there are observational studies, and the secondary analysis of these kind of RCTs show that, again, when you're thinking about a GLP-1 agonist versus placebo, the GLP-1 seems to produce a significant amount of reduction in alcohol intake, but it wasn't a consistent finding, throughout the whole. So if I'd gone to your first study, I would be saying, you should have got the results from the first study. That kind of stuff. So observational studies also showed fewer alcohol-related healthcare events in the people with GLP receptor. Okay. Are there any clinical trials to date? There's one clinical trial for ghrelin antagonist. And if you go and have a look at that clinical trial, it's quite disappointing. This has been PF 519-0457, which is trips off your tongue very easily. That's actually been around for a wee while. It's all we can say is it's definitely safe to use in AUD patients, but the results from it really are not enough for me to actually say that's what we should be thinking about. But I think, I can't remember, I think Rama, we talked about it, certainly, we talked about it. We need to think about clinical trials that are properly conducted in this area. All the clinical trials, and certainly this one that has been completed, it's a single-blind placebo-controlled trial. And really, we know that the gold standard is double-blind RCTs, is what everybody wants to do. Second, the sample size was N equals 12, 6 and 6. So it really doesn't tell me anything very much. Third, it was actually done in a lab setting. So there was no natural setting for it. Now, are there clinical trials for GLP? Again, there's only one that actually has been completed. And it does seem to suggest, they tested exenatide to see if that actually reduces drinking. And it was, and again, I'm trying to think what was the bottom line in this. So it may limit AUD in some patients, especially the ones that are obese, as I told you, as it was in the first study, which was not part of this clinical, is separate. So this has actually been done at least twice. That shows that if you pinpoint people who are morbidly obese or obese, then you might get a good response for GLP-1 bringing us quickly to the conclusions, this access is worth us thinking about. It's certainly an emerging area, like the psilocybin story. It really is a place that we should be thinking about, and there's a real scarcity of, there's a a very small number of effective trials, effective treatments. Ghrelin and GLP-1 are the only two that we can think about because there are no drugs yet that are licensed for PYY, no drugs yet for oxyntomodulin, no drugs yet for all the others that we have. But I think they certainly would be something that we could think about. And you know, while there is evidence, especially from the rodents, but we really don't have any patients. So there should be, this is what we should be thinking about, whether, especially in a place like this, that we can do this and do this quite reasonably. Yeah. So, look, guys, this was before COMI, by the way, Prof. M. No Center of Metabolism and Inflammation. This was when I was Adipokines and Metabolism Research Group. And Prof. M, actually, because I moved here and Noura was still doing her PhD. Luckily, she happened to come from Kuwait. She said, I'll come with you and do. So Prof. M allowed her to come to ADLQ and finish off her studies. That's why she spans across the both. And now this work is, of course, Dr. Khalifa Rama here. And all of the obesity studies that I describe here were actually from the Whittington Hospital and my colleagues over there. That's it. Thank you very much.
Thank you very much, Professor Vidya. Any questions from the audience, please?
No.
Thank you very much. It's fantastic. Just one question. If you conduct a clinical trial with the GLP-1 in alcohol or substance use disorders in a normal BMI, what do you think about the side effects to lost weight after?
This is one of the things that smokers have often complained of weight gain, you know, so it might be good for that. But perhaps, unless they have obesity as a problem, which is some of the things that I've showed you, when you're thinking about alcohol, it's been most useful in people who are morbidly obese. And that's still irrelevant. So we're going to have to think and go down the route that Prof. M was saying and see what is the best fit for you. And we can go from what has fitted in so far. And I would say, and you do have enough number of obese patients too. So perhaps we can start with them, if a small trial, before we think where we're going. And again, if you were to ask the question about what dose, difficult to say. We know that in diabetes, you go for a much lower dose than you go for in obesity. Are we going to go higher still? But then what are the side effects? I mean, I'm not sure that I, would feel great about my patients being sick. Not being able to drink or have whatever hit because he's sick all day long, or she. Yeah.
Glenn.
Yeah, thank you for the talk. It was really, really interesting. I know it's early days, but they say with the GLP-1 regulators that once people come off their appetite, it comes back. Is there any evidence that with alcohol use disorders, whether or not the alcohol cravings will come back as well?
Yeah. I mean, it's basically would be seen like diabetes, that it's a chronic disease. And you're pretty much going to have to be on that, for much of your life. There is no evidence that suggests so far, whether you're talking about obesity or you're talking about SUDS, that these are going to, or diabetes, that these are going to be drugs that you take for a month, 2 months, and then no more. I think it then stays with you as your one day at a time kind of thing.
Thank you, Professor Vidya. Our next, in fact, the last speaker is Dr. Akif Ali Khan. Let me introduce him. He's a consultant psychiatrist working in Naufar. Dr. Akif's career spans over 20 years in mental health within United Kingdom. He started as a junior trainee and later worked as a consultant. His most recent roles includes consultant addiction psychiatrist in Nottingham, as well as working as a visiting consultant for Steps Together Rehab in private settings. Today, Dr. Akif will be speaking about the effects of glucagon-like peptide, GLP-1 agonist, carrying forward Professor Vidya's session, on substance use disorders, craving, and it is his reflections on the use of these medications in the field of addiction. Please join me in welcoming Dr. Akif Ali Khan.
Thank you very much, Dr. Shahid, for the introduction. First of all, I would like to say two things. Firstly, I feel like a medical student coming after Professor Vidya and all the other esteemed colleagues. So if my presentation is not to par, then please excuse me on that. Secondly, somebody has obviously leaked my presentation and notes to Professor Vidya, and she has already answered all my questions, all the questions from people. Okay. But to start with, we are talking about, following on from Professor Vidya's presentation about GLP-1 agonists, and essentially SUDS, or the substance use disorders, represent a significant global health challenge with high relapse rates and limited effectiveness of current treatments, underscoring the need for novel therapeutic treatment we all have been talking about today. Now, GLP-1, a hormone involved in glucose metabolism and appetite regulation, has been found to interact with neural pathways, which are related to reward and addiction. Now, today we have explored and will continue to explore the neurobiological mechanisms by which the GLP-1 agonist may modulate substance craving. Focusing on the effects on the brain's reward system, as well as preclinical studies, talking about them. We have already talked a little bit about the studies done in rodents, as well as the clinical trials, also the ones which have been published in Lancet, BJ Psych, and others. But as previously mentioned, there are very few, and more research needs to be done. Now, I would like to start with the basics, essentially, to be honest, and let's talk about the Lancet's Global Burden of Disease study, which consistently found that mental and substance use disorders contributed significantly to the global burden of disease. Within its category, substance use disorders and mental health illnesses had a substantial impact on health, which led to increased disability-adjusted life years and years of life lost. In 2019, the rates in the US per 100,000 population was roughly around 3,900. And over the 30 years of that study, the years lived with disability increased in drug use disorders to 17%. And then the burden of this SUDS was higher, obviously, in countries with lower socio-demographic index. So, as I said, going just back to the basics of describing addiction or a substance use disorder, it's a chronic and often relapsing brain illness, affects a person's brain and behavior, and is characterized by persistent cravings. And that's why I had to come to this point of cravings, which is an inability to stop using the substance despite negative consequences, and changes in brain function that make it difficult to experience pleasure in activities previously enjoyed. Also, the neurobiology of addiction, which involves brain reward system and neurotransmitters like dopamine. And this is one hormone that we deal with every day whenever we are prescribing antidepressants, antipsychotics, and many more. And when a person uses addictive substances, the brain's reward system is activated, releasing dopamine, creating feelings of pleasure and reinforcement, and leads to a cycle where the individual feels like taking the substance again and again. And due to the treatments that we have available, there there is a significant side effects of current medications, and these present a challenge in treating substance use disorders. And often we will have relapse rates in individuals with SUDS, leading due to persistent cravings and triggers associated with substance use. Now, the brain's reward system plays a crucial role in this process, and this is where the GLP-1 comes into play, and we'll be talking a little bit about that. So GLP-1 is an incretin hormone that increases insulin secretion and helps reduce blood glucose levels after a meal, and it has been doing that for me since afternoon. Medications like the liraglutide and exenatide, we touched upon them earlier on. These are the usual GLP-1 agonists. And just briefly about an article in BMJ about the liraglutide and cardiovascular outcomes in type 2 diabetics found that the liraglutide reduced the risk of major cardiovascular events in patients with type 2 diabetes, and also showed all-cause mortality to be lower as well as cardiovascular mortality, and improved overall outcomes in people with type 2 diabetes. Now, this GLP-1, or the incretin hormone, promotes feelings of fullness, slows down digestion, and can lead to reduced calorie consumption. It is released from the gut after eating and acts on receptors in the peripheral nervous system, including those in the vagus nerve. This can lead to slow gastric emptying, which helps to regulate nutrient absorption and reduce hunger signals. The GLP-1 can also enter the brain and act on receptors in brain regions involved in appetite regulation, such as hypothalamus, and that further suppresses appetite and enhances feelings of satiety. And by slowing down the digestion and reducing hunger signals, GLP-1 helps to limit the amount of calories consumed, contributing to weight management. Now, the dopamine pathways and the GLP-1 signaling are connected, with GLP-1 potentially impacting dopamine release and activity in brain regions involved in reward and motivation, and potentially even addictive behaviors. Now, GLP-1 receptor agonists, like the ones we have been talking about, can activate GLP-1 receptors in the brain, particularly in areas like the ventral tegmental area and nucleus accumbens, which are key components of the mesolimbic dopamine pathway. Now, the GLP-1 signaling can influence dopamine release, potentially reducing it in response to food stimuli or drug cues, and this can lead to reduced reward-seeking behaviors. So essentially, by modulating the dopamine activity, the GLP-1 may affect the reward-seeking process, potentially reducing the pleasure derived from food or drugs. So, drawing parallels between overeating and substance abuse behaviors reveals intriguing similarities in how the brain's reward system influences both actions. And that's what Professor Vidya was talking about. Both overeating and substance abuse involve the activation of brain's reward pathways, particularly those involving dopamine. And this is responsible for creating feelings of pleasure and reinforcement, which can then lead to repetitive behaviors aimed at achieving those pleasurable effects. In the case of overeating, the consumption of highly palatable foods, especially those rich in sugar and fat, umeali, triggers the release of dopamine in the brain. This creates a rewarding sensation that encourages individuals to continue eating even when they're not hungry. Similarly, substance use involves the use of addictive substances that activate the brain's reward system, leading to the release of dopamine and reinforcement of drug-seeking behaviors. Now, some of the agonists which are in practice, we have talked about liraglutide, semaglutide, and exendin. And some studies or the preclinical trials have been done on all three of them. So a small study, again published in Science Direct, showed that the exendin reduced alcohol intake and seeking behavior in rats. Same is for liraglutide. There was a study published in Oxford Academic that it reduced alcohol intake and preference in male rats, mice, and non-human primates. And semaglutide shown to reduce alcohol intake and prevent relapse like drinking in rodents in a study published in the National Institute of Health. A study in the journal Addiction, in the journal Addiction in 2024 aimed to estimate the strength of association between prescriptions of GLP-1 agonists and the incidence of opioid overdose and alcohol intoxication, and as well as patients who had opioid use disorder, respectively. So the results were, even though they were looking at the extreme of the drug use, that is the looking at patients who had taken an overdose, but what it showed that because of the strength of the study, because they had more than 200,000 people who were recruited between 2006 and 2023 in Sweden, that the primary exposure that they were looking at was whether the people who were taking the GLP-1 agonist had any impact on their hospitalization post-overdose. And they found that the use of both semaglutide and liraglutide was linked to reduced risk of hospitalization because of somatic reasons, but also that both sema and liraglutide had the lowest risk for both AUD-related admissions. Also, earlier on, we talked about the effect on nicotine and whether there's any clinical data on that. So there's a small but growing preclinical literature indicating that the GLP-1 agonists attenuate voluntary nicotine taking and seeking behaviors, as well as nicotine withdrawal induced hyperphagia and body weight gain in rodents. Now, consistent with these findings, clinical studies indicate that agonists reduce nicotine withdrawal, hyperphagia, and body weight gain, which are the two main obstacles in quitting smoking and achieving long-term abstinence in male female smokers. There's also a functional MRI study suggests that glucagon-like peptide, the GLP-1 receptor agonist, may reduce the abuse liability of opioid analgesics by modulating cue reactivity, working memory, and the dopaminergic reward systems. And especially exenatide has been shown to reduce activation in the DLPFC, which is the dorsolateral prefrontal cortex, during working memory tasks in patients with opioid use disorder and compared to a placebo group. Now, just briefly, I wanted to talk about a SNAP survey of a patient group that we did right prior to this symposium, just to look at the local population and the use of GLP-1 agonists and the impact on their cravings and how whether it has been beneficial for them. And just quickly looking at some of this has already been talked about. So we looked at population of patients with only 237. That's not the population of patients the total number of people who registered with the hospital, but because it was a SNAP survey, so small number of patients. And we looked at the substances they were using, whether they have had any bariatric surgery, use of obesity, diabetes medications, and any other, as well as chronic disease. And within this population of 200-something patients, we had only 96 who were using methamphetamine, and then so on, alcohol 32, heroin 26, and others were using cocaine, methadone, opioids. Even though I think this is opioid maybe needs to be up there somewhere, but specifically in this, the diagnosis of opioid was less. And the high use of obviously methamphetamine may reflect regional substance trend as well. Now, within this, we found that the patients who had been using GLP-1 or had been prescribed, obviously not by us, they were having it from private hospitals or from the HMC, that the medications were either Mounjaro, Ozempic, or Wegovy. And the primary motivation for most of them, so out of the 28 people who were prescribed these medications, they said that they were taking it for weight loss. A lot of them were not aware that it may have had an impact on their craving. And it's mainly for the health reasons. So they took them between 3 and 12 months, and the side effects, some of them reported, like mood changes and nausea and vomiting and low appetite. So the important bit is that roughly around 5% of the population that we interviewed in the SNAP survey said that they had some benefit from in terms of their cravings to the substance use. So it kind of brings me back to the point that there is scope for more research into this topic as to whether we can do research, especially in a population here where we have a lot of control over and records leading to knowing what patients are taking or not. And also there's a lot of scope for research into whether we can increase awareness in patients who are using such substances just for weight loss, or whether this could have an impact on their drug-seeking behaviors as well. Now, the GLP-1 agonists, they are promising new multifaceted treatment option for SUDS, potentially. And by targeting both the metabolic and neuropsychiatric aspects of addiction, these could revolutionize current therapeutic paradigms. Essentially paving the way for improved patient outcomes in addiction medicine. I think I'm going to just conclude with this. Thank you very much for listening. I know it's the end of the day, but I really thank everybody for visiting. I know a lot of you have come from a long distance away, and it's really nice to see some esteemed colleagues and new faces and listening to the research. So thank you again.
No, thank you, Dr. Akif. Any questions from the audience? No?
If not, then thank you very much. I really appreciate you listening to me.
Sorry, that wasn't a joke. Okay. I don't think anybody can see me, by the way. I'll just go on. Okay. Thank you all for a very insightful and productive day. We appreciate all the engaging discussions and valuable contributions surrounding all the topics that we've covered today, basically. For our international guests, we hope you get to see some of Doha this evening and the rest of your stay. I just have 2 messages from the education team. They're asking that please bring your badges for tomorrow, so for ease of access. And those are collecting CPD points. Please make sure you clock out tonight as well. So see you all tomorrow, day 2. Rest up, because we have some more exciting sessions tomorrow. Thank you very much. Let me just put it on